That's what I heard too. But I'm just, I think I'll be talking just before you. So I'm just waiting for those guys to
to log
come
in.
and start. Yeah, I'm in the US. I'm not.
Hello, my name is Andrew Cron, and I'm a EP from Vancouver. I've been involved in genetic testing pretty much all of my career for 30 years, and I'm honored to be invited to the Indian Heart Rhythm Society and your meeting in Calcutta as a virtual speaker. So I have been asked to talk about genetic testing in arrhythmia patients, and so I thought we'd spend the next 15 minutes talking about this, and then I'll do my best to wake up at 3 in the morning and join you for questions and answers. So here are my conflicts of interest. So one of the things I do now with lectures or talks like this is I go to ChatGPT and I ask, what could anyone in the audience find out by simply asking the same question about what is the role of genetic testing in heart rhythm disorders, particularly around inherited conditions? And what you can see here that I'm not going to go through is it gives a remarkably good answer about the idea of what genetic testing is and how it works and when you might implement it, how it's utilized for family screening, some of the ethical and legal and social things to consider, and then where future directions are. So I'm not going to focus primarily on information, more around the processes of what happens with genetic testing to give you a sense of how it works in my practice running a cardiogenetics clinic for a long time. We run a national registry for the same reasons, and I'll give you some details and references at the end. So one key thing I think to tap into is something that are the most up-to-date guidelines in this area, and this is on the whole content of the conduct of genetic testing and who and how. And this is a multi-society collaboration that was completed 2 years ago and talks all about the way in which genetic testing should happen. So if you're going to remember one thing, look up this reference because it will be a very valuable reference and resource to you in learning. I want to start by presenting a case. So this is a 62-year-old Asian woman, and she has a cardiac arrest while she's getting ready for work. And her husband actually hears a thump because she's in the bathroom and he hears a crash and a thump, and he actually works as a firefighter. So he's very capable. He sees her, checks that she's unresponsive, has no pulse, calls 911, and does CPR until she can be resuscitated. And she's resuscitated and brought to the hospital, and then we get involved from a heart rhythm service from the standpoint of the cause of the cardiac arrest and the need for a secondary prevention ICD. The interesting thing in the story that she says is that she had a 13-year-old daughter who died suddenly. And she was at a church event and they were playing some kind of a game and she collapsed and could not be resuscitated. There was a long downtime. And so some of this was the delay in getting access to resuscitation. But interestingly, she had seizures before this, and the seizures were under, it's quite vague what the circumstances were since this is a long time ago, but it's kind of suspicious that these may have represented arrhythmic syncope with secondary seizures. And her only real past medical history is hypertension, and she's on hydrochlorothiazide, and she had a recent urinary or upper respiratory tract infection, but in fact, she's not been unwell and she's not been febrile. So, and this is the first ECG that we saw. And so interestingly here, she's being cooled. She's in the ICU. And she does make a good recovery. Her husband did very good CPR, and this is her resting ECG. And you can see her, she's quite bradycardic. That sort of fits with her cooled state. And one of the things that you might observe is that her QRS looks relatively normal. Her QT actually looks somewhat prolonged. But in a cooled state after cardiac arrest, this kind of changes can be normal. And so then there's the question of what else could be up. And she has our usual investigations for cardiac arrest, which includes a coronary angiogram and an echocardiogram, and both of those are normal. So she has no occlusive coronary disease, just normal left ventricular function. So what we did as an exercise test and as part of our workup, our ASPER unexplained cardiac arrest workup, and early in exercise, then she does this, where that relatively unremarkable looking ECG, then her QTs paradoxically prolong. The T wave morphology changes dramatically to that of a notched T wave with a very prolonged QT interval. So we now can make the diagnosis of clinical evidence of long QT syndrome. And with that comes a strong suspicion that that was the cause of her daughter's sudden death, and helps to then direct her potential treatment and then direct that information to screening other family members. And so we did genetic testing in this instance, and this is just an example of looking up the variant that was detected when we did genetic testing. And you can see immediately it goes from something like, did the genetic test show something, to something that's potentially feels complicated. So you get sequencing information, gene information. A person like me who does this all the time will be suspicious from that T wave morphology and the paradoxical QT prolongation that she has type 2 long QT syndrome. And that information then becomes a testing grounds upon which to both educate her, but also screen her family members. So if we talk about the logistics of genetic testing, so I'll talk about how this works in our environment, and this is largely applicable, but everybody's own local health system and access and the platform in which this could take place in India is something I'd like to learn more about. But it's complicated. It's more complicated than a yes, no, or most other tests. And so what I'll illustrate is some of the complexity, some of the utility. And what I will say is that for most people, if you don't do this on a regular basis, you need to find the people who are experts and either partner with them or delegate to them. And the core person in this process is a genetic counselor. And a genetic counselor in our environment, in Europe, it's often a nurse, but it's a person who has the ability to counsel and give consent, arrange for blood or sputum testing, send the information to a commercial lab. These are mostly in the USA and Europe. And the cost is very different in different systems, but it can be 1,000 to 1,500 Canadian dollars, euros, US dollars, depending on environment. And family members often are either bundled in as free with the index test or a low charge. And of course, the nature of the test is driven by what the clinical tests show, and it usually takes 1 to 3 months to get information. So that's the basics. The key person in this is a genetic counselor for us. And again, it could be a nurse. They typically have a master's. They have a lot of genetic expertise. They work as part of a team. This is something that since 2013, we've advocated that this involves a team. They educate and they're a resource to people. They construct a family tree or pedigree. They discuss the condition and its inheritance. They coordinate the testing, communicate with the family, and often provide summaries for teams when we meet to discuss complex cases. And in effect, they provide support for patients and their families. So the role of genetic testing, there's 3 situations that I think it's pretty clear that genetic testing is helpful. So the first is you have a diagnosis in an index case, the proband, and the positive genetic test then aids in the specifics of prognosis and therapy. And so a good example with arrhythmogenic right ventricular cardiomyopathy is there's basically 8 different genes that cause this, and they actually have different risk scores, different prognosis, and different manifestations and mechanisms by which you would follow this. That information then facilitates family screening, and it can sometimes be helpful when you have a suggestive test, and then the genetic test can guide whether you clinch a diagnosis or it doesn't support the diagnosis. It's not useful for people who have borderline evidence of disease. And it's important for patients to understand the complexity of it. And I'll illustrate a bit about how we classify genetic testing results and whether these are variants of unknown significance, which is a typical finding in a large panel where there's some degree of uncertainty because you detect natural genetic variability. And none of these conditions are absolute. And so the yield of testing is in the order of 20 to 80%. But not 100%. So you can have ARVC without a positive genetic testing. You can have Brugada and long QT and so on. And so the genetic test is part of the testing process, and it isn't the answer to do you have long QT or not. So when to consider this in some more specific instances is, for instance, patients with familial hypercholesterolemia often have signature lipid levels. But if the lipid profile fits, there is a genetic test for that. When there's a cardiomyopathy in evidence, like hypertrophic cardiomyopathy or ARVC, or we now like the umbrella term arrhythmogenic cardiomyopathy. When there's evidence of an ion channelopathy, and it's also obviously useful in screening first-degree relatives. And by now, we actually do a lot of our testing with sputum, which is easier to do, doesn't require blood storage. Patients are less averse to it because there's no needle poke. And can be useful in victims of unexplained sudden death. And so molecular autopsy is not a new thing. It's been around for almost 20 years and can be useful in 10 to 20% of cases. It may be worth considering genetic testing in the context of a family history and a borderline phenotype. My sister has long QT. I don't have access to her details or genetic information, and I would test somebody whose QTs are borderline. And also when you have a phenotype and a positive or negative test really helps to guide the probability of, for instance, need for treatment or family screening and so on. But you must not, please do not test somebody who has a family history who does not have a phenotype. So I do not believe in direct-to-consumer or random population screening of use of genetic testing. I think you just, particularly if you're comprehensive in the scope of testing, you find much more uncertainty than gains. So the implications of the genetic test are important, and this is where the genetic counselor can be very helpful. And if you are the physician without those kinds of resources, then you need to be aware of this. So it can help to confirm the diagnosis, and certain genes, for instance, have specific prognostic implications. It helps to then guide the value of certain therapies like beta blockers, like flecainide, like ICDs, for example. It also helps to identify relatives. And one of the most wonderful things we do every week in clinic is meet people whose genetic test is negative. And then we say, your tests, your genetic test did not show the finding that's going on in your family, and we can say goodbye forever. The downsides, our testing's not always 100% sensitive. There are false negatives and false positives. And there are negative impacts for people if they are gene carriers who have a varying degree of a phenotype, and that can impact things like career, insurability, hobbies, sports, and so on. And knowing the local implications of these things for their ability to do some of these important life things is very important. And you can create anxiety in relatives who are low risk, who are found to be gene positive with not much or no phenotype because of their perception that they are at high risk. And then the last thing is that variant interpretation, which I'll talk about in a moment, is an imperfect skill. It evolves over time. New information is constantly exploding really online in terms of the scope of variants that are available for comparison. And so control populations and their variants then inform the pathogenicity of the genetic findings that are detected. And so this is one of the sort of foundational things in our field, is this whole idea of classification of variants. So what happens now is your sample goes and gets sequenced at a lab, and that sequencing is actually not that complicated and not that expensive. Much of what you're paying for, what's involved, is actually the interpretation aspect, because it involves not only referencing online materials, but in vitro, species preservation, and any precedent or existing literature that's published on the variant. And so then the two things we're most interested in are ones that are classified then as likely pathogenic and pathogenic, because these are clinically actionable. They fit with the diagnosis of the index of why you conducted the test. And what happens when you do a typical cardiac panel in the modern era is you're testing 200 to 300 genes. And so what you get is what's in the middle there, that variant of unknown significance. You detect natural variability within the genes that you're testing, but they have no known or recognized association with disease. And so as a result, they're not actionable, but they create uncertainty. And then they also create responsibility to track the variant of unknown significance in the event it's found to be more common in certain control populations, particularly as we diversify ethnicity of control populations, or they're found to be associated with disease when you do segregation within large families and so on. So there's evolution, if you like, of the genetic information that comes even from direct sequencing. So then what happens at the end of this is you get a genetic test report. So here is an example where we've most commonly used a lab in Finland called Blueprint Genetics. They provide excellent service. They were a company that was founded by cardiologists. And then their panels, they collect a great deal of clinical information. And as a result, they'll return a result like this in somebody who ended up carrying a variant that seemed explanatory for their clinical problem. And then they will give you a broad list of resources that are available to you that can be used to put the genetic information and the clinical context of, for instance, previous published information into your patient's care model. But again, in our instance, the genetic counselor is a big part of helping to process this information, put it in context to help to guide how we apply this to the patient and their family. Public resources are also simple. If you have a genetic test and you see, like on the bottom right there, you will see something that represents KCNQ1 as the gene, and then you have sequencing information, and then the immuno.
So exactly about to start the first session of our day, the advanced therapy, if the advanced therapy. So for this, I request to Dr. Somir Rane, Dr. John Roshan, and John Dinesh Prabhu, Dr. Dinesh Prabhu, to get on the Dr. Sandesh Prabhu, very sorry, to get on the stage for chairpersoning the session. And our first speaker, Dr. Indranil Basuroy. Okay, so our first speaker is Dr. Indranil Basuroy, and he'll speak online. Yeah, he's online, and we'll speak on heart failure, what's new EP.
Can we start the session? Good morning. Good morning, Dr. Indranil.
Hi, good morning. How are you?
I'm good. I'm good. How are you doing? We can start the
Not too
session.
bad. Perfect.
Yep.
Can you hear me clearly?
Yeah, audible.
Perfect. You want me to start?
Yeah, you can start.
Perfect. So let me share my screen. Let me know if you can see my screen.
Yes, we can see.
Thank you. So, I'm a cardiac electrophysiologist. We are going to talk about advanced therapy in heart failure, a cardiac electrophysiologist perspective, because we are the doctors who provide these therapies, not the heart failure guys. So, we did one of the first barostim in the US, maybe in the world, I'm not sure. So, I'm going to talk about that today. So we have this guy, 56-year-old male, shortness of breath, dyspnea on exertion, fluid retention, fatigue. He has had multiple hospital admission. He got a Medtronic CRT placed in 2022. Persistent atrial fibrillation by by a partner of mine. He came to me. I did an atrial fibrillation ablation with radiofrequency ablation before that in 2021. Normal sinus rhythm, but after that he continues to have multiple hospital admission with the heart failure. Symptom: New York Heart Association class 3 on full dose GDMT. His latest EF is 15%. So the prevalence of heart failure all over the world is staggering. Over 22 million people. I don't want to give all the statistics here, but in the US, around 8 million. India is believed to be around 1.3 to 4.6 million people, and over 500,000 to 1.8 million annual incidents every year. That's a very sad story. And it's true for India also that heart failure is the most common cause of hospitalization for cardiac reason. Mortality is 15 to 20%, which is 3 to 4 times higher than any other developed country, including US and the Western Europe. Um,
Hello.
Heart failure remains the most common reasons for rehospitalization also. And the sad story is just like India has malignant coronary artery disease, India tends to have malignant heart failure with younger, sicker patients getting heart failure. Now, the clinical course of heart failure, if we take a quick look about the clinical course of heart failure, you'll see this, that once you initiate GDMT, and even if you manage to give people the full dose GDMT, there's a progressive downhill course. Then they come to a place where they start getting device therapy. They are class 2, class 3 then. And then comes where they are class 4 and they become candidates for transplant or LVAD. So this is the period where electrophysiologists like me come in combination with heart failure guys to help these patients. Now, GDMT improves heart failure morbidity and mortality, but that lasts for a very short time, 1.4 to 6.3 years. So if a guy at the age of 40 has a severe MI, non-revascularizable or even revascularizable, but the progressive heart failure, the guy has a life of 40 more years. But if you give him a therapy that lasts for 6.3 years, that's not going to be good for him. So, what else do we have? For almost 100 years, we really had nothing. Around 20, 25 years back, we had something called CRT. So CRT, as you know, is given with guys with left bundle branch block pattern with more than 150 milliseconds of QRS. And this is the result of GDMT and CRT. So GDMT, unfortunately, despite in the highest doses, when you give all the four drugs, causes very little improvement in exercise tolerance, very little, very modest. But whereas if you go to CRT, especially if it's class 1 indication, that is QRS is greater than 150, the exercise improvement is quite a good amount. Unfortunately, that is not seen in patients whose GDMT, whose QRS is intermediate, that is between 125 to 150, but not more than 150. But the tragic story is, despite being excessively successful procedure, it is only usable in a very small percentage of patients. 70% of patients do not have an indication for CRT. The people who do have full indication, again, unfortunate part is that up to 16% have intermediate sized QRS, that is QRS between 125 to 150, when unfortunately the results are much more dubious than in the class 1 CRT indications, where the results, as I just showed you, is extremely good. So then what is the alternative? GDMT doesn't work long enough. CRT is not available in 70% of the patient. So this is how you do CRT. Most of you being cardiologists and electrophysiologists know about it. I'll not spend much time. The So if you look at the CRT data, there's a huge number of people, as I just said, who are negative responders. So this pie chart is amongst people who are CRT candidates. Despite that, only 22% are super responders, 35% are non-responders, 22% are negative responders, and 21% are non-responders. So that's a huge number of patients. So these are people who, even after 6 months of therapy, they either have the same or in large number of cases worsening EF, just like the patient I showed you in my screen. The other important thing that is important to remember for us electrophysiologists who treat heart failure patients, and almost all of us do the same, is what heart failure patients look for is quality of life. They are not looking to be lying in their bed for the next 40 years. They want to walk their dog. They want to go out on a normal day, have a walk just like you and me. They don't want to have pain. They don't want to have discomfort. They don't want to have 5 or 4 times admission in a hospital every year. And certainly they want to have less anxiety and depression. But we know that 65% of the patient, based on large number of trials in different heart failure trials, they prefer improvement in symptoms than actual longevity. Now, in the last couple of years, we had multiple new therapies. For example, cardiac contractility modulation, about which I'll not talk today because the time is limited. And the other big is Barostim, about which most of my talk will be today. So Barostim is a device for heart failure. So let's go quickly through the pathophysiology of heart failure. So heart failure, we know there's a decreased baroreceptor signaling. There's increase in sympathetic tone, there's decrease in parasympathetic tone, and there is increase in heart failure symptoms, giving rise to increased heart rate, increased remodeling, decreased diuresis, increased renin secretion, and renin including all the bad players, whether it's angiotensin 1, angiotensin 2, endothelin, the most powerful vasoconstrictor known to mankind, and a whole bunch of um, abnormal hemodynamic mechanism is stimulated due to the autonomic imbalance we see in heart failure. And this is a progressive phenomena. So what we do in Barostim, basically, we put a lead in the carotid artery on where the vagus nerve is. Vagus nerve lives along the bulb. We put there, and then what I do is we tunnel it, make a pocket in the chest there. That's where we put the actual device. So studies have shown that barostim decreases sympathetic tone. As you can see in the screen, the teal shows the sympathetic tone. The one on the top is the sympathetic tone in worst heart failure without barostim, and the way below are the ones normal people, you and me, with no history of heart failure. Barostim also increases increases parasympathetic rate, decreases sympathetic, but it increases parasympathetic tone. And the parasympathetic tone can be modulated, as I shall talk, how we as electrophysiologists modulate the device, just like you modulate an ICD or a pacemaker into refrequency and high frequency. And based on that, you can increase HRV, which you know is a marker of mortality in these patients. There are multiple trials, but I'll just talk of one trial because of shortage of time today. In this trial, in the pre-market, it clearly showed that the 6 months improvement was there. NT-proBNP was improved. Based on the post-market, it decreases CV death. Hospitalization was plus minus. It does decrease all-cause mortality. It is very safe. And based on that, it was allowed by FDA. I'd not spend much time going into the BEAT-HF trial, but it's a standard population, as you can see, between people getting Barostim and people who are controls. Now, going through what is the effect of this? Why should we do it? So if you look at the 6-minute heart failure score, you will see the one in teal is what Barostim does. One in red is the control, or orange is the control. One in green is the difference. So there is 44 meters increase at 1 year compared to controls. So you will ask, who the hell does just 6-minute walk to describe a device? You're right, my friend. These are soft parameters for heart failure. But let's not forget contact CD, and let's not forget miracle. 25 years back, this was the exact measure we used to see if CRT works. And the history is getting repeated. All the newer devices passes through the same pathway that CRT once upon a time passed, and now we know CRT works, so nobody asks any question. So we go through the Minnesota score, we go through the 6 minutes walk. This is the Minnesota score for you. Again, teal is barostim, orange is control, green is difference. You can see marked difference. Actually, the difference in 2 years is almost similar to contact CD and more than what we saw in miracle trial. And p-value for barostim, when you compare to what CRT did, is p-value is significant. Now, what about the improvement in functional status? There is a functional status improvement by multiple factors, and that's where this particular slide shows. If you look at 6 months, 12 months, and 24 months, there's a sustained improvement of ejection fraction and functional class. I'll talk about ejection fraction slightly later. Let's talk about functional class improvement here. Barostim, orange is the control, and the difference is in green. And again, down there, you can see the trials with CRT in its initial days, not the heydays of CRT that we saw in the last 5 to 10 years, but almost 22 years back when contact CD and miracle was done. I was, I think, a medical student then. That's what they showed. So if you compare head to head, more functional improvement with barostim than these two trials which had with CRT. If you look at the reduction in advanced heart failure intervention, that is LVAD, CRT, use of cardiomems, this is way better. The barostim is the upper curve and lower curve is the control. And the funny part is, even after 48 months, and that's one unfortunate part about barostim, we do not have long-term controls, we do not have long-term results. This is the most results we have. It's a new device approved by FDA. It's still a straight line. It does not dip down. But look at the control. That's the normal phase, the nasty phase of heart failure. Everything fails ultimately, and the patient goes through a vortex of vicious cycle of recurrent hospitalization leading to death. No wonder people say that heart failure untreated is worse than all cancer other than gastric and pancreatic cancer. So we as cardiologists have to be extremely aggressive in trying to treat this disease in every way possible. So the reduced risk we see in barostim is almost 72% of that. Now this is the MACE. If you look carefully, we don't use the word MACE here, we use the word MANCE here, M-A-N-C-E. We have used neurology also because remember, this is a neurological device that changes heart failure because it basically stimulates the vagus nerve. So we use the MANCE, M-A-N-C-E rather than M-A-C-E, and even rates are given here between subjects which are controlled and the events. Nothing strikes out very abnormal. Now, a serious cardiovascular effect in 6 months are the following. Cardiac arrhythmias is reduced by less than 50% compared to people without barostim. Chances of angina decrease 44%. So it does have some people with chronic ischemic cardiomyopathy who are non-revascularizable. It does decrease angina. Hypertension syncope is also decreased, but a small number, around not a small number, around 63%. The total relative risk reduction is to the value of 51%, which is important to note, has not reached a p-value of significance, though it does have a significant number, but p-value, unfortunately, in the present trial till now has not shown significance. But if you look at the symptomatic improvement of responder at 6 months, you'll find that 94% have symptomatic improvement, but which means that 6-minute 1% quality of life based on Minnesota is more than 5 points, and your New York Heart Association class improves by 1. So if you're class 4, you become class 3. If you're class 3, you become class 2. But 79%, which has not been shown in any trials till now, are actually super responders. Like you have super responders also in CRT, where 6-minute walk improves by 20%, quality of life improves by 10%, but New York Heart Association comes back to class 1, which is super responder status. The relative
Thank you. Thank you for the informative talk. Next, we'll move on to the next talk by Dr. Prashant Sanders. Is it online?
Are you able to see slides?
Dr. Prashant?
Yeah, can you hear me?
Yeah, we can hear you. Good morning.
And can you see the slides?
Yeah, we can see the slides. You can start
Perfect.
the session.
Perfect. Thank you very much for having me, and greetings from the US at this point. So I'm going to talk about how to set up a comprehensive AF management clinic and to put it into context. Look, one of the things I wanted to show you is this slide from what we did at APHRS, which we have data here from India as well in terms of the burden of atrial fibrillation. And what it does show is that there are 80 million people in our region with atrial fibrillation. And so realistically, the whole world is going to be focused on us to lead how we should be managing atrial fibrillation in terms of the burden to the healthcare systems. We know in white individuals at least 30 to 40% lifetime risk of atrial fibrillation. We don't have accurate data in our region itself. But we know that about a third of people over the age of 40 are now going to have atrial fibrillation. And while we've ignored this condition to a large degree, there are hard endpoints, and these are now set out in the recent AHA guidelines in terms of what the risk for additional disease is, whether that's death, stroke, dementia, sudden cardiac death, MI, heart failure, etc. And so we do need to look at how we can better improve our therapies and better implement guidelines to our patients. Now, anticoagulation, we've known about the data for a long time, and I want to show you this this study. This is the Gloria AF registry, and it's kind of telling on a global perspective that none of the regions are doing very well in terms of something that we've known about as proven evidence for some time. And our region in Asia is perhaps the worst in this, in terms of using antiplatelet agents, in terms of not using anticoagulants. And so we have an important job on how to implement therapies that the guidelines have included as proven therapies for our patients if we're going to improve the outcomes. Now, we've tried to introduce a couple of concepts in the recent guidelines. We've had guidelines from the European Society of Cardiology, but also the AHA ACC guidelines. And I want to show you this one just to highlight a couple of points here. We introduced the concept of AF Care as a acronym that can be used. And one of the things we did here is we moved comorbidity management up front, because we think this is going to change how everything else falls in the patient with atrial fibrillation, what the disease course does, what anticoagulation will require, how they have rate or rhythm control. And so this is emphasized by moving it right up the front. A is obviously avoiding thromboembolic events. Then we have the reducing symptoms by rate and rhythm control. And again, to emphasize the E component of this, which is evaluate and dynamic reassessment. And something that we didn't do very well, which is that each year that our patients get older, they get more comorbidities, they have different risks for bleeding, different risks for heart failure, and it really is a sign to say, hey, you need to look at your patient and reassess them at least once a year in terms of where they are at, rather than making an assessment once and forgetting about that reassessment. And we wanted to make this that it's a responsibility of all healthcare professionals who see patients with atrial fibrillation. So I think this is an important slide that we included in the ESC guidelines. Now, very similarly, we gave a different impression in the AHA guidelines, and here we put this story of the pillars, but we made the modifiable risk factors the central pillar of AF management, again highlighting the importance of this to the population. We highlighted that there needs to be access to all patients for this sort of care, and that we need to actually enact a behavioral change as part of our AF management. And in the bottom of the steps, we put what's the foundational component of this again as each of those modifiable risk factors. And I'm going to talk a little bit more about those in terms of the clinic. So we did put a lot in this figure so that this was available for clinicians to use at the bedside. So having told you that we're not doing well with proven therapies already, what I'm going to tell you is our group made it even more complicated because we drew attention to the fact that we now have a plethora of modifiable risk factors, which has also become part of AF management. And listed here is obesity, physical inactivity, hypertension, sleep apnea, diabetes, dyslipidemia, alcohol, and also smoking. And the reason these are here is each of these are known to modify the atrial muscle such that it promotes atrial fibrillation. And so we just need to be aware that these are things that we can actually impact and change disease course. You guys are all aware of the data that we presented on this, but I just want to, in terms of setting up a clinic, put this slide up because this slide gives some of the targets for therapy that we need to be aiming for. We call this comprehensive risk factor management. Comprehensive in that we are treating each risk factor that is relevant for that individual patient, whether that's weight, exercise, diabetes, whatever. Each of these is kind of listed here. I want to highlight that we're presenting here at the AHA this year data on South Asian weight targets, and it's going to be a lot stricter than what we've used in white individuals. So I think this is something that's going to be race specific and region specific, and we need to be paying attention to how these targets are going to change in the coming years for what we need to be doing. And I guess the other side of that is we've got new drugs as well, you know, whether it's SGLT2 inhibitors, whether it's GLP-1 receptor agonists, we need to kind of work out where that fits into this equation of a comprehensive risk factor management. Now, one of the studies that took my attention in terms of developing an AF clinic is this work from Harry Kreins and Jeroen Henriks from Maastricht. Now, what they did was a really simple concept. They took patients coming to the AF clinic. One group was seen by the physician. The other group was seen by a nurse supervised by a physician. But the nurse had a computer program that provided a checklist of whether they were going through each of the investigations that were needed, each of the drug therapies that were needed to ensure that they were receiving guideline therapies. Their primary endpoint was a big endpoint, cardiovascular hospitalization or death, and then they had secondary endpoint of whether they had guideline adherence. They really recruited a large group of patients, 712 patients, an average age that would be expected, and striking results where they showed a significant reduction in cardiovascular death and hospitalization out of a very simple maneuver, that is creating a clinic which has a checklist run by a nurse concurrently with the cardiologist. They were able to see a hard endpoint change in their patients. Now, we worked with Jeroen to look at the long-term mortality outcomes in these patients, and this is the outcomes that we published. Its persistent mortality benefit of all-cause mortality over a very long period of time as a result of ensuring that there was a way of delivering guideline therapy and implementation of the guidelines. And so I think we need to all take a good hard look at how we're running clinics in order to see if we can do this better. I want to show you how we've done it in our team, and it's maybe not the only answer, but it is a answer that works. We've divided our team into an AF management team and a risk factor management team. And the reason for this division is that there's just information overload for the individual if they're trying to deal with all the information we're giving them about the rhythm, as well as all that information about risk factors. And so we need to kind of break this down into bite-sized bits. One of the key things is for the patient, the AF team is the most important. That's what they've come to the physician with. And so that team has the key job of motivating the patient to see the risk factors as an important factor in trying to manage this. And so I think this teamwork, kind of giving a unified message, is an essential component of how our clinic has worked. The risk factor clinic we've kept really simple because it's within the resources that we're going to be able to afford. It's either been a physician or a nurse. We've also had a pharmacist who's done it individually. We've had EP fellows who've done this. Okay, so it is a transferable thing. And this person is the one person to take responsibility for it. There is administrative support where booking of appointments and things. And the appointments are quite long. So that's why I think it needs to be outside of the EP physician's realm and more in the preventative cardiology or nurse practitioner realm. They're long appointments, they're every 3 months. And if we see that a person is not achieving their targets, we see them more frequently or have contact by email, and that expedites the management. We rarely have to refer patients out of the clinic. Most of this is managed within our own service. The one thing that we've sent everyone to is for a sleep study with a sleep physician, but even that we're bringing in to our clinic with the WatchPat device, being able to give that out like a Holter monitor to our patients in order to be able to get sleep apnea results. And there's a rare patient where we've not been able to get on top of their diabetic control. We use biguanides. We're now introducing SGLT2 inhibitors and GLP-1 receptor agonists, and with doing that, we're reducing the number of people being sent to endocrinologists over and above what we're doing. So it's a simplistic clinic, and it seems to work. The change in behavior is nothing new, and it's the same for all chronic disease. And the first step is the thing that we don't do so well, and our nursing colleagues do really well, and that is really to understand the motivations for the patients, their education level, what level to speak at, why they do certain behaviors, what's important for the family, and how we kind of convince them to make a change. They need to decide to make a change, and that once that decision's made, we need to give them a plan which is achievable. Now, most patients give themselves targets that they'll never achieve, and most of the time we're talking patients down in terms of what they need to achieve, because if they achieve it, they're then motivated to keep going, whereas if they don't achieve it, they pull out of the program. This is a monitoring process. We then give them new targets, and in this way, we achieve habitual change over time. So none of this is new. It's just breaking down what's supposed to be done in chronic care management. We published this now as part of the AFNet era consensus conference as the Adelaide model, just as a stamp to say this is something that we can base it on in terms of establishing AF clinics. We're working with HRS now to try and get some streamlined outputs for this as well. And so this shows the division of clinic. And then I've put together this slide to give people some details that can be followed in terms of that structured educational visiting, what kind of screening needs to be done. I'll introduce this head-to-toe concept towards the end, but then the achievable targets and the final targets. Now, we've got a software that we're working on to try and improve what the information the trainer gets, so that we can, with minimal training and the software, that software prompts what sort of changes can occur. And we're going to be working with AJ, who's speaking next, in terms of evolving some concepts into his program where this could be delivered almost automatically to expedite this sort of management in the EP clinic. So I'm going to leave you with this last slide, again emphasizing that there are multiple elements here, but central to the management of an AF patient now is the modifiable risk factors. And the steps of this, we did introduce earlier into the literature of having to review the patient from head to toes. Okay, heart failure, exercise, arterial hypertension, diabetes, tobacco smoking, obesity, ethanol consumption, sleep apnea. This is an acronym that clinicians can use at the bedside to try and work through what is reversible in the person with AF. And this is going to need to be the first step in terms of our AF management for our patients. So we're hoping that we can roll out some more information and digital health platforms to help all clinicians with this in the near future. And I look forward to kind of discussing this further with you. Thank you.
Thank you, Dr. Sanders, for your talk. Any questions? If no questions, then we can move on to the next talk. This is an extension of the AF clinic into our homes, probably. Telemedicine and AF by Dr. Ajay.
Thank you, Dr. Sanders. And let me share my screen. I need to share my screen and I don't see the share button.
Yeah, and Dr. Ajay, the cursor, yeah, there's a share button. Can you see that? I mean,
Yeah, now I can see it just popped up now.
yeah, slideshow, please, and we can start, Dr. Ajay.
So telemedicine in AF, advance this. As Dr. Sanders was just alluding to, the prevalence in US in the last decade has been about 3 million, but projected to go to 16 million, and similar in Europe. And as he was alluding to hospitalizations, deaths, strokes, and in-hospital mortality, it costs about $28 billion. Biggest main role is the risk factors, as Dr. Sanders just was discussing, but there are other social determinants and health factors that come into play. Then this slide he already shared. I just wanted to show that Asia Pacific actually has 80 million, and this was just a month ago or 2 months ago. This came out in cardiology reviews that shows India has 22 million, and the total combined is 80 million. So there is no way that the current workforce can handle this as we start treating these patients. But the patient expectations are that they want their health journey simplified, convenient, and cost effective, and on demand. But the current state is the access can be an issue. Barriers can be cost, geography where they're living, urban versus rural, versus Africa versus rural parts of India or Australia. For patients to get care, it's a multi-step process. And the elements of AF care problem from a current state for a health system and providers and payers. At least in US for payers, it's value-based care that are at risk contracts. There's money at stake. For providers, increased patient volume, complex care needs, workforce strain, repetitive tasks that can be automated. For payers, higher health costs and long-term care burden. And for health systems, longer stays and higher readmission rates and rising operation costs. So how do we tackle this problem? I'm just taking an example of Baylor Scott and White, that's where I work. Currently, the biggest challenge is patients being aware of atrial fibrillation services, thinking of Baylor Scott and White when they need the services, but also puts a lot of staff time, nursing staff, providers in education, educating the patients, seeing them on time. If they had ablations, pre-visit, risks of ablation, post-visit, post-ablation care, a last-minute cancellation of procedures, or triage of patients to appropriate phase of care, hospital versus a quick outpatient cardioversion or a timely ablation, avoiding readmissions. These are all the different challenges that an AF clinic has. So the current AF patient-provider interaction, as most of you know, you educate them, you review their history, you schedule them for different treatment options, but patients have their own treatment barriers. They're worried about their cost versus safety. And at least in US, you do this 10 to 12 times a day per provider. So the current telemedicine current state may solve the geography barrier, but may not solve the access or the volume problem. What if you start complementing this with digital health and generative AI? That may ease the access and volume problem. How is that done? By automating some of the tasks, the education, reviewing the history, scheduling components, addressing their treatment options, treatment barriers that can be made into transcript review and personalized for the physician to quickly look at it and give recommendations based on parameters and protocols. And the call center becomes an adjunct rather than, and then the generative AI platform becomes a middleman augmenting the service of the call center and the provider. The current AF journey, as Dr. Sanders just reviewed, you have, they can be seen in the emergency room, they can be admitted, they can get to the lab or be referred to the EP clinic. Then they have interdisciplinary clinics for risk factor management. Then they have the specialty clinics for structural heart watchmen or ablations. But if you have a generative AI and a software solution, can all of these go into the background where suddenly the journey of the patient becomes much easier? And so how do we get there? So you need to first start thinking about the patient as a whole. First, you need to understand what the social determinants of health of the health they are, like where they are in the status, their literacy levels, their understanding, their economic status. That probably needs to be fed with the patient's behavior towards the disease, their willingness to change. We presented a few articles of how to create tailored nudges to patients with the atrial fibrillation and how to change, understand the stage of change and where they're in the change and what kind of nudges may work for each phase of change. And then there's the integration layer, because in order to personalize these digital health apps, you need to integrate them with EMR and wearables and then lifestyle apps. Then you have the clinical journey where we are giving recommendations that are specific for AFib. And then there is the appointment, the non-clinical journey that the patients have. This whole thing completes their experience as a patient. So then you have again the integration layer for their disease-specific journey. And together with the education bot, that's when you can create a virtual assistant that can automate most of this process. But is that simple? The answer is no, because to create these agentic AI models, augmenting employees to be supercharged medical assistants, nurses, or physicians that can take care of the current take care of the burden, but also meet the current expectation of the consumer. There's a lot that goes into training, developing and training in each agent. You need to have first a training curriculum for your model, but also for the people who are going to use it. The model should be able to understand the vocabulary of the domain. Then you need to fine tune it. Then you need to teach it how to perform the skill. You need to add an empathy layer, but then comes the most important part of evaluation. Evaluation depends that the model should be explainable, that has several components that you need to think through. They need to be interpretable, trustworthy, fair and transparent, accountable, privacy and security, robustness. But these also depends on who is evaluating these models. Is it a physician who is evaluating? Is it a patient who is evaluating? Or is it a data scientist who is evaluating? Then you need to guardrail the agent. Is it an education knowledge agent? Is it a behavioral agent? Or is it a clinical agent that does the decision support? Or is it an administrative agent that does the scheduling? You need to guardrail them within their confines, and then they interact in the background. The ethics of this, then you need to have a governance structure. This is just getting started. Then comes the validation. That's where you need to have partnerships that are very extensive. You need to have industry partnerships, EMR integration, because without EMR integration, you cannot personalize, because you need a context platform for any generative AI agent to be mature enough to develop, give personalized recommendations. Then you need early adopters. We are working with Dr. Sanders at University of Adelaide, and then regulatory, the FDA regulatory, because non-serious informed stage is a class 1, but once you start getting into clinical decision support, it's a class 2 classification from FDA. Then you need to deploy the model for production, and then you need to do a continuous improvement. These may take 6 to 8 years and a lot of money just to get through this different agents and train them. So before you build any AI solution for any disease journey, the questions that one should probably ask is, who is going to pay? Who benefits from it? In our case, the patient, support staff, physicians, and the health system, the insurance, who also are the payers too. How does it improve? Does it improve the experience, or does it improve the outcome? So you need to have clarity. Why is it better than the current process? So can this automation, is it more efficient? Is it going to be more cost effective? Everyone can say you have ChatGPT, but ChatGPT without guardrails is prone to hallucinations, is prone to security risks. What are the upsides if you succeed? What are the downsides if you fail? And where is the data going to come from to train these models? Does it already exist? When should it be built? Should you build a production-ready solution, or should you first go through a prototype? These are all the questions that we have asked as we were building our models. And my conflicts of interest are, we have an ownership stake in Alfred AI, and also grants from Microsoft and Baylor Scott and White. We have grants from Baylor Scott and White. Thank you. And the one last thing is, just to give you an example, the security threats and risks. When you have a generative AI solution, there are different security threats risks. If you have the chat history, you can have data loss, hallucinations, you can have toxic output, you can lose your logging data, or user file exfiltration. What that means is you can ask your training data saying, hey, so-and-so had this, can you give me his history profile? Unauthorized retrieval, you can have data loss through prompt, or you can inject prompts, toxic prompts. You can have data loss during file uploads. You can have LLM resilience issues. You can have data poisoning issues. So these are all the things that you need to take into account when you're developing your generative AI apps. So with that, I'll stop my talk.
Thank you for the nice presentation. If any questions from the audience? If no question, we'll move to the next session by Dr. Senthil T. Stepwise approach to PV isolation with the Flex protocol using Tactiflex catheter.
Hi, good morning. You guys can see my slides?
We cannot see you. Yeah, we can see the slide now.
Okay, thank you for Indian HRS for allowing me the opportunity. We've taken a different little tack. We're going to talk about stepwise approach to pulmonary isolation with the FLEX protocol. This is my biography. I'm an electrophysiologist in Dallas, Fort Worth, Texas. We're going to show this slide as an actual case presented using our MedInbox, which is a recording audio video software that can not only record the cases live but also can be transmitted internationally for any collaboration. So we use intracardiac echo to reduce X-ray exposure. Here we have the intracardiac echo going into the right atrium. Home view, looking at the septum. Here we see there is a thick upper limbus and a thick lower limbus with a narrow fossa and a narrow septum that we're going to cross. We get all these pictures and also the baseline effusion and the posterior wall. Then we go into the right ventricle, anterior flex. We look at the free wall of the RV, apex, LV function. And then as we clock, we start to see the left atrial appendage. As you can see here coming into view, the more you push into the right ventricular outflow tract, you can see not only the apex of the left atrial appendage, make sure there's no thrombus, but also the ostium to determine before we put any catheters into the left atrium for the AFib ablation procedure. So here we have the first transeptal that is obtained. We got it in the thin portion. Then we proceed to the next transeptal. We use usually the radio frequency wire for transeptal. The difference from a BRK or a radio frequency needle is you need to pre-shape the sheet. Sometimes if you have a dilated atrium, like I said, we do double transeptal, one for the mapping catheter and one for the ablation catheter for the procedure. Here we're watching the Baylis sheet being loaded on behind the RF wire. We do use from fluoroscopy, but this can be done with zero fluoroscopy as well. So a little faster speed to get through the case. And so we have the second transeptal positioned. Then we proceed to mapping using the multipolar HD grid catheter, creating a shell of the left atrium. This is the HD grid catheter from EnsightX, using the EnsightX software. And then once we create the shell, we start the ablation. This is where some of the parameters of what we call the FLEX protocol comes into play. Usually we start at the left superior pulmonary vein, keeping it at the antrum. I tend to use 45 to 50 watts anteriorly. This is the new TactiFlex catheter, which has contact information and also vectors to point out the direction. And usually I use 6 millimeter automarks for each of my lesions. And there is also an interlesion distance that is available on the software. And I tend to keep it below 6 millimeters to give a contiguous lesion. Most of the lesions, I follow two rules. One is the maximum is 10 seconds per spot, or if there is more than 10 ohms impedance drop at the particular site. And you can tag, these colors that are tagged are based on the impedance drop. So anything more than 10 ohms impedance drop is generally a good lesion, and those are marked in darker pink red colors. When we now come to the posterior wall, as we can see, we're on the bottom of the left inferior pulmonary vein. Then we go to 40 watts in this area. So here we see the lesions being started. We use intracardiac echo. As you can see, almost no fluoroscopy at this point. And the left lower screen over here, you can see the HD grid catheter with signals that is put past where the ablation is done so that you can monitor real time for isolation of the pulmonary veins. And with this protocol, generally we tend to have a high rate of first pass isolation of the veins. Sometimes there is obviously, you can see on the posterior wall, there's esophagus on the intracardiac echo image. So when there's a temperature rise, you may have to give that site a break. And the contact force information, generally I try to keep at least 5 grams, closer to 10. Anything more than 15 to 20, you probably are on the higher side and you don't need more than 6-7 second lesion. So here we're gonna just keep watching till we can get to the isolation of the pulmonary vein. You can see signals on the yellow marked spline catheters of the multipolar. As you're starting to finish up the left pulmonary veins, you can start to see some organization. As you can see, we have the two numbers we follow, 40 watts, and then the impedance drop, which automatically drops the color so that you can then stop the lesion when it's more than 10 ohms, or if you're given more than 10 seconds in a spot, generally you don't. Based on our internal database that has shown that this has the lowest incidence of steam pops, and what we looked at the x-ray, we moved the coronary sinus catheter into the RV. One of the advantages of the Inside X is you can switch between voxel and a magnetic mode and impedance-based mode. Because we have had some vagal during ablation of the roof areas, we have switched to see that the coronary sinus catheter is placed within the V so that we can have some backup V pacing during the ablation. Now we are going to go back to the left atrial map, switch to voxel mode to finish up the pulmonary vein isolation. Because in the roof where we were ablating, we were seeing a lot of vagal and bradycardia from the ventricular response. As you can see on the left lower screen, you can see that we're pacing from the coronary sinus catheter that's in the RV. But if you notice the signals on the yellow lines, there's some red lines. As we're finishing up the roof and finishing up the posterior wall, you will see that the signals are going to organize, and there we have first isolation of the left side pulmonary veins. And we're finishing up the circle, map it, then we go to the right side pulmonary veins. The ablation catheter is in the roof of the right superior pulmonary vein, and we're going along the anterior wall of the right pulmonary veins. The HD grid catheter is in the right superior pulmonary vein. Now we are moving back the coronary sinus catheter, because we don't have any vagal on that side, back using the map, pulling out of the RV and into the coronary sinus so that we can have monitoring of the atrial fibrillation. Here we're doing the anterior side of the right pulmonary veins. And as you notice, most of these lesions are less than 10 seconds. Contact information is between 5 and 10 grams. And as much as possible, try to keep the definitely the distance between the two auto marks below. Some of the fractionated points are also marked with those dark fluorescent green. So as we are finishing up on the right superior pulmonary vein, we'll still see some conduction happening along the arrows, and the new Inside X software and the HD grid mapping catheter you can see not only does it have where the electrograms are, it also has some vector information which shows you where the earliest activation is coming in. So when you don't have, this automatically does what you would have to do looking at the EGM yourself to see which is the early entry site and follow it, especially if you don't have a circular lasso mapping catheter. This multi spline catheter keeps track of where the earliest is, and there are features on the software which gives information on where the earliest is in terms of entry or leak in the Waka that you have done. Here, based on the arrows, it looks like the leak is in the right anterior side. And once the mapping is done, we will put the ablation catheter. So you can see the arrows all leaking and mostly focal from that point. And the colors represent where the early is. So white being the earliest activation of EGM into the pulmonary veins. So once the full mapping is done, here you can also see that the white is more anterior compared to the posterior. So on top of us looking at it ourselves, the software has features to automatically give this so that it can be done with just one operator without without having to go back to the electrograms yourself. And so we have narrowed down the spot where the earliest activation into the pulmonary veins was. We're giving lesions, and you can see we have achieved in the left lower complete isolation of the right pulmonary veins as well. Then this is a persistent case. So we are typically do pulmonary veins and the posterior wall as well. So here we're doing the roof. We have the HD grid catheter in the posterior wall. As you can see, the early activation shows that the arrows are coming from bottom to top, not from top to bottom. So the leak is along where the box lesion is not completely done. This is just to show proof of concept. And also the white markers, the white color usually indicates, the beauty of this is this patient is in irregular atrial fibrillation, but is still able to determine based on that irregularity, even where the earliest activation is in the beyond the line. And as we finish up that box, you can see complete isolation of the posterior wall. So for a persistent atrial fibrillation, you can do it in atrial fibrillation to see if they organize. But with the TACTI Flex catheter and the Flex protocol with the HD grid mapping catheter and the Insilex software, we have simplified some of the ways that we can achieve first pass isolation and complete isolation. So just to summarize about the ablation protocol Flex, we use 45 to 50 watts anteriorly, 40 watts posteriorly, 10-second duration lesions, or at least a 10 ohm drop in impedance, whichever comes first. So many lesions need not be more than even 6-7 seconds, definitely not more than 10 seconds. It seems to have the, based on our internal database from other doctors, but also from us as well. And then 6 millimeter automark and less than 6 millimeter interlesion distance seems to give the best ways of achieving first pass isolation. And thank you for allowing me the opportunity to present on this topic, and appreciate the time.
Thank you, Dr. Senthil. Any questions? No questions from the audience. We shall move on to the next talk.
There is a slight change. Dr. Jaipandan has a flight to catch, so he'll be presenting next. Dr. Jaipandan, ablation of ventricular arrhythmia in channelopathy.
Okay. Good morning, everybody. First of all, I give a sincere thanks to organizing committee for giving this opportunity and preponed my talk, and apologize to my colleague Karthikeyan sir. In between, I am coming. In the AFib, instead of that VT, I am coming. So the ablation of ventricular arrhythmia in channelopathy, and it's not moving. Yeah, thank you. So the channelopathies like inherited syndrome caused by mutation in genes and subunits were with primary called as electrical disorders, where we know the long QT syndrome, Brugada syndrome, idiopathic VF syndrome and short QT syndromes and CPVTs also. Here, main presentation is life-threatening ventricular fibrillation is a common cause of sudden cardiac death in patient with channelopathies. The initial strategy remain avoidance of triggers and structure, whatever the triggers we can avoid and give the medical management like beta blockers and some specific antiarrhythmic therapies. Finally, we can plan for ICDs ultimately as a class 1 indication for SCD survivors and primary and secondary prevention. So most of the time we think of ablations beyond the medical management and ICDs, VT stroke and recurrent stroke from shocks from ICD, it triggers like PVCs. So aim of these patients, eliminating the triggers and scar modification are the two main strategy, even though it's a class 2A indication in the VT stroke patient. So at the recent years, the growing interest of exploring the catheter ablation to treat the VF in a patient with the channelopathies, those who are in stroke. While catheter ablation is effective in the monomorphic compared with our channelopathies like polymorphic and VF. It's associated and scar tissue with the monomorphic is a success rate is high. The success rate of VF ablation generally lower than the whatever our expected group than the monomorphic VT. So I already told about it's a class 2A indication for VTVF stroke in patient with the channelopathies. We'll go through some example how it is channelopathies patient turned to be a VF. You can see the one of the example CPVT patient. It started 2 or 3 bimorphic VPC which turned into the VF, and case 2 and is a bigemini VPC. Some of the VPCs turned to be a VF, and third case it's PVC triggering by isoprenoline or wash off in the lab. That's also is a easily inducible VF. These and all kind of cases where channelopathy is easily inducing the VF. So where are all the triggers and presentation of VTVF triggers? The originate in the polymorphic ventricular VT or fibrillation from mainly in the lateral basal wall and septal area, maybe in the around 25 to 30%, and RVOT 12%. Especially Brugada and long QT syndrome is a predominant presentation of trigger or VPCs from the RVOT, especially in the epicardial region, and both septal equally contributing that, and Purkinje fibers also triggering for PVCs. So we'll go for some case studies. Some group of people did a VT and VF ablation for the all 4 channelopathies. This group, Louis Jean, is group ablated in the trigger elimination by catheter ablation in PVC, which is triggering the VF in the CPVT. Those who are not flecainide and in flecainide with after PVC ablation, that high risk of syncope and recurrence is less compared with the without ablation patient. This is the how they mapping. Sometimes they pace map and triggering site can ablated. This one they have ablated in the septal region where the trigger is earliest from 20 milliseconds, where intracardiac recordings of catheter position at the successful of polymorphic ventricular tachycardia, which is triggering for which is triggering by PVC, which 14 millisecond early, which ablated. After that, there is no PVC burden and recurrence of VF. Another example for long QT ablation, the epicardial, most of the time it's epicardial arrhythmogenic substrate only in the long QT syndrome, which is triggering for PVC. The group of Carlo Papani group ablated few patients initially. When they are published, they did around 15 to 20 cases. Further, now 23, they uploaded some cases, same ablation. Their success rate is high. So the abnormal electrogram extended from the epicardial RUOT and infralateral region. The catheter ablation targeted over that area and homogenization done the substrate where that area. You can see here various type of substrate present is a continuous signals and fractionated one, double signals. These and all epicardial origin. You can see here they are explaining and that after ablation of the substrate, their QTC also is corrected in the table itself. It's not seeing properly. If possible, you can see the paper. It was 513 in the initial phase. Once ablated and on the table itself, it reduces 463. So this is a case they initially presented, then follow up the add-on case. They are planned to publish few more cases with study. Have a success rate one. Next one is a Brugada. The patient is considered to be a high risk sudden cardiac death, which is seen nowadays in our practice. I don't know, we are in electrophysiologists then, so that's why we are getting the more time of cases. And ICDs are considered as a effective therapy. And however, in spite of pharmacological medical management with quinidine, and still the electrical storms are there instead of with ICD therapy. These are target site of ablation in Brugada in epicardial. Technically, it was present in the most of the cases in the epicardial origin, and these are sites for predominantly present the scars and VPC triggering area. And this one you can see like a long QT syndrome, there is a lot of epicardial continuous signal and fractionated signals where it is become a homogenized by CA, and after that there is no PVC and VTVF burden is less. That another group of patients that they are also explained about a lot of potential which is triggering the VPC, which is a response for VTVF, where they homogenize it, and after that there is no VT burden or shock. This is they are given Nedumane group. They ablated. Before that, you can see their Brugada pattern, the coving type, it's completely disappear after 3 months of ablation. That is also observed in our care group of patient, 4 or 5 patient in 4 or 5 years back. This is a paper, catheter ablation in electrical storm in the Brugada syndrome. So results of substrate-based ablation. Usually other Nedumane group and other groups are they are targeted in the epicardial. But here we also got some epicardial group, and endocardial also targeted, like endocardial and epicardial RUOT region in the abnormal potential targeted. Brugada pattern gradually resolved as like a Nedumane paper in the post RFA of 1 week followed by 1 month. There is less ICD giving a discharge. The 24 follow-up, 4 out of 5 patient, no VTVF. You can see that it is our case where we have a endocardially fractionated potential. It was before ablated ECG. That next one is after ablation, that coving pattern of Brugada is disappear after a week. Conclusion, the very rapid advancement in arrhythmia mapping in catheter technologies. The role of ablation is expanding the disease like channelopathies, where several studies demonstrated the effectiveness of epicardial catheter ablation in RVOT and extension part for the high risk of sudden cardiac death, which suggests the catheter ablation should be integrated part of channelopathies patient, those who are in high risk of sudden cardiac death. especially long QTs and CPVT and Purugada syndromes, and advocate for careful informed decision regarding the selection of candidates for catheter ablations and evidence-based approach defining the optimal medical management pathways for cardiac channelopathies. But usually it is for regular ablation. It is not for regular ablation. We have to take the patient, those who are in ICD and those who are in VT storm and stop. Thank you.
Thank you, sir, for your presentation. Because of time restraints, we'll move to the next talk. Dr. Karthikesan will speak on cryo in AF tips and tricks.
So good morning, everyone, as respected chairpersons and my dear colleagues. So after listening to the talk from Dr. Sendil, how we can efficiently use the RF ablation, point by point RF ablation, we'll move on to the single shot ablation technique for atrial fibrillation. So as of now, the single shot is many more are in pipeline. As of now, what is available in India is a cryo balloon, which is available in some other centers in India. It is many more centers are going to adapt it. So with my limited experience, I will share my knowledge and how we can do this procedure very safely and effectively to this our atrial fibrillation patient. So as of now, you see that atrial fibrillation. Those who are not seen, this is a console which is comes with a. There is a console and there is a FluxCat catheter within that, which is a deflectable catheter, 15 French, and there it goes the balloon, and the balloon is also a deflectable, and within that there is a Achieve PV mapping catheter goes in, and this entire setup is connected to the console through the coaxial umbilical cable where the nitrous oxide goes, and there is an electrical cable connected to the temperature monitoring. This entire assembly comes. So how we can use this entire setup for the effective and safely we can do the procedure. So I will touch upon some of the very important aspect, pre-procedure workup and vascular access and transeptal puncture, catheter manipulation and balloon occlusion and phrenic nerve protection and post-operative procedure care. So pre-procedure workup is very, very important. The first bottom line is the case selection. So case selection, I would rather recommend the proximal AF patient or the ideal patients for this procedure. Very or early persistent atrial fibrillations. Unknown duration, long, many years of atrial fibrillation patients may not do well with this procedure, especially in cost-effective constraints with our country. So it's we are very better off selecting paroxysmal atrial fibrillation with the LA size of less than around 5 or less than 5.5. And transthoracic echo to see the LV function, LA size, LA volume, and any other structural or valvular heart disease is better to do it. And transesophageal echo to rule out LA clot, LA appendage clot. It is very important. Either the day of the procedure or a prior day, we will do the transesophageal echo to rule out the clot. Nowadays, I stopped doing CT. Initial few cases of cryos, we did CT chest to assess the pulmonary anatomy. Once we got experience, so we can stop doing that CT chest for the purpose of pulmonary anatomy. But sometimes the transesophageal echo, if you have suspicion of clot, if you want to be rule out or confirm, CT chest helps for the appendage clot. Our anticoagulant strategy is a skip bone dose of most of the patients are on DOACs, so usually most of them are apixaban. So when you are doing the procedure of the morning hours and I do the previous day night dose, if you are doing the afternoon procedure that day morning dose, I skip it. If a patient is on rivaroxaban, I just ask them to take previous day morning itself so that it vanishes of 24 hours. So that's our strategy. And we always involve the anesthetist, pre-procedural anesthetist or checkup, because these procedures are usually done under sedation or conscious sedation with the fentanyl, midazolam and propofol infusion. And suppose anesthetist is not very comfortable in giving that due to short neck or LV dysfunction or comorbidity or whatever it is, then go on general anesthesia. But majority of the cases, my experience is done under IV sedation, conscious sedation only. The femoral access is very, very important because of the white sheath, the 15 French sheath. We don't want any vascular complication. We adapted nowadays to the ultrasound guided puncture. Arterial line is not mandatory, so we can go for a radial line if it is anesthetist feels that hemodynamic monitoring is very important. Or a sick patient, radial line should be okay. The crucial for the successful ablation for either the RF or the cryo, transeptal access is a very, very important thing. So you can see this transeptal puncture here in LAO view. It is little lower than the, usually we get the lower puncture as compared to mid-septal or any high septal. We can manage to eliminate the pathways, but for the better occlusion, better manipulation of better accessibility of all four pulmonary veins, either by RF or either by cryo. So you need to get a lower and as well as a posterior puncture. You can see that more in the 90-degree view, we can see more towards IVC puncture is preferable. In the aortic view, it should be a little away from the aorta. And if this is very, very important, if you have facilities to eyes, you can use the eyes. If you have a transvisual echo, it's preferable to do is the transvisual echo gatal puncture, either one of that. But it is not mandatory fluoroscopically also, certain extent we can do it. In RAO view, you come down just below the level of his or below the his level catheter, at the posterior you can puncture it. I use SL1 sheath and BRK1 needle. It's very important not to slide over the septum, give the adequate curvature so that where you are intended to puncture, you can puncture it. Otherwise, it will keep going, slipping, and any other catheters. Once you puncture it, put a 3-2 wires and give the heparin. I used 100 units per kg, heparinized saline, and run the heparinized saline through the flux catheter. And the target ion is ACT is around 350 before starting the ablation. Once you put the flux cath inside and run the heparinized saline infusion, then prepare the balloon, adhere the balloon, put the achieve catheter, connect all the cables and insert it inside. But the first thing comes out of the flux catheter is the achieve catheter, that is PV mapping catheter. So never push the balloon outside, so without an achieve catheter that will scrape and create trouble. So the achieve comes out and put it in the pulmonary vein, and over the achieve catheter you advance the balloon and then inflate and try to occlude it. So certain tips, if you are going for the upper vein, the left side upper vein, upper branch of the upper vein always gives good stability, good orientation, good alignment, good occlusion, and good ablation as well. Same thing for the inferior veins, the inferior branch of the inferior vein, put the wire in the inferior branch of the inferior vein, you can see that instead of upper vein, inferior branch of the inferior vein, you put it so that also gives better alignment and stability and better delivery of energy. And also avoid malalignment. You should multiple bends, you should avoid it. You should everything in a coaxially if it is present everything. Again, that gives better occlusion and better energy delivery and better successful ablation. The cornerstone of the cryoablation is the balloon occlusion. So you need to occlude. That occludes confirms that you are in a good contact, so that so your energy delivery will be efficient. Ablation will be very efficient. We can see that here. So the completely occluded, and then the dye is not coming out, so where you can comfortably deliver the energy. So you can see the right superior pulmonary vein here. So sometimes it's not possible, you may have to use a LAO or a view where is the leak is happening, superior or inferior or sidewise. So you need to turn the balloons either clockwise, anti-clockwise, or flex or deflex it, either balloon or catheter. Flux catheter, you can manipulate it, all are flexible one. So you get the alignment properly so that you are occluding comfortably, so that your energy will be very efficient. Still, if all the techniques and tricks, if you are not able to occlude it, so you can do segmental. If you leave the inferior leak to happen, so ablate the superior rim, then you will deflect it and ablate the inferior rim. That is the last option. Sometimes for the inferior veins, you have to use the hockey stick appearance. You can see that hockey stick appearance because to get a good occlusion, push the catheter up so that it comes like a hockey stick and give complete occlusion for this patient. Common osteum is one of the problems, which is quite common in the left side pulmonary veins. But majority of the common pulmonary veins with a single shot, you should be able to ablate it. Or sometimes the two lesions also you should be able to ablate it. May not be the problem. But very big osteum, antral region, you have to do the segmental isolation, like superior, inferior, and right and left by clockwise, anti-clockwise is a 4 segment you can ablate it. But majority of the cases, the 1 or 2 ablations, you should be able to complete the complete ablation. You can see one of the common osteum patient where you can see that is ablation happening in the superior vein, and the same area is little deflect and put the achieve in the inferior vein, and the balloon position is not much changed, but because of the superior inferior orientation of the common osteum, so you put the 2 pulmonary veins and occlude it. It's possible. So verification of the occlusion is very, very important. So you can fluoroscopically, which I showed that, with the other is eyes, other is a pressure monitor. I will show the examples. Here you can see we are injecting the contrast. You can see the leak is happening. Little advance the balloon. I can see you can advance the balloon. Then you inject the dye. It's nothing. Leak is happening. It's completely occluded now. So the occlusions are graded. The complete occlusion is grade 4. Sometimes grade 5 occlusion where you are not even seeing any filling near the balloon, but only seeing distal, it's almost like a grade 5 occlusion. This sort of grade 4, grade 5 occlusion is important to not to have a leak but a good ablation. So immediately temperature drops and then we can see the very good isolation of the potentials. Again, ice helps for the alignment as well, and the balloon is not too much inside. You are in the antral region, occlusion, everything. You can demonstrate it by things. You can see the leak is happening in this, and little advancement in manipulation, so the leak is stopped here. So without any fluoroscopic, without even any contrast, you can confirm that complete occlusion of the vein with this ice catheter. Other is the pressure monitoring. We can see the waveforms A and V are seeing that. Atrial fibrillation, you will not see the regular consistent A waves, but you can see that sometimes A waves and V waves. Once you forward push and occlude the vein, you can see the monophasic V wave alone is seeing that. You can see this chart. Once you occlude it, its amplitude increases, it forms a uniform waveforms, or V alone, you are seeing that. Once you that without any contrast, this confirms that you are getting occluded, and then you can start, you can see this chart once you occluded it and then start freezing it. As you see here, you can see the big PV potential, the green color and all PV potentials. This is a CS catheter, there is a HIS catheter. And then as you go on with the freezing, you can see that the potential is getting separated. You can see it is coming out of that signal. As you see, you can see the timeline in the EP tracer. If you connect it, you can see the timeline. You see the signal is coming out, and then you can see that in 40 seconds, you are able to see that almost 40 seconds, the pulmonary potential is gone, and you are isolated the vein. So in a single shot with the 40 seconds, you isolate that, then you continue for around 240 seconds. You can see the left infrapulmonary veins, you can see the separator shot happened, all the small potential you are seeing that, then it is gone here. So these are all with a single shot you can able to do it. What is the time to isolation is very, very important. You should get isolation of less than 40 seconds. That is has a durable, considered to be very durable, and long-term outcome to be going to be very good, more than 80% of the specificity for lack of recurrence. How long one should do it? Usually right side pulmonary vein 180 seconds and left side we go for 240 seconds. But the people have studied it. If you are able to isolate it less than 60 seconds, then you can give 2 more minutes so that around 240 is more than sufficient. And if you are able to isolate it more than 60 but less than 90 seconds, then give 2 minutes and give bonus solution of 2 minutes. And if you are not able to see any changes in up to 90 seconds, then come off with the freezing. There is no point in continuing the freezing there. So if you are able to, some of the patients in a chronic patients or little persistent patient, you will not see any pulmonary potential at all. In those patients, give 2-3 minute lesions and good occlusion, 3 minutes lesion, followed by another 2 more or 2 minutes lesion, so total 5 minutes. And then all those patients, you have to check the exit and entrance block, which is very important. Phrenic nerve is one of the most important complication of the cryo is the phrenic nerve injury. Various ways we can monitor the phrenic nerve injuries. One is that put the ice catheter in the hepatic veins and move the diaphragmatic movement directly. And the other thing is compound motor action potential, which is commonly we use in our lab, which is where the right arm lead has been placed on the zipisternum, over 5 cm over the zipisternum. Left arm lead is placed over the costochondral margin, which records, you can see that the red line, you can see that the lead 1, which gives, once you start pacing the phrenic nerve, put the this catheter, CS catheter or whatever, his catheter in the subclavian vein, right subclavian vein, start capturing the high output. And if you are doing the patient under general anesthesia, you have to tell the anesthetist not to use any paralytic agent and start stimulating it. You can see that. So you can see the nice potential, you can see that amplitude, you can see that once started decreasing it, then that indicates the phrenic nerve is getting injured. You should come off immediately. There is an option is available, double tap technique. Immediately balloon deflates so that you can avoid injuring the phrenic nerve. That's a very important complication, the most common complication. So one has to be very, very careful about it. It's easily avoidable, and so you can see this pulmonary vein as again the isolation has happened. You can see the CMAP amplitude is continued to be the same level we are maintaining. So post procedure is very important. We go compress it or sometimes figure out how we will put it. Observation for cath recovery, then goes back to the room. We don't keep them in ICU. DOAC started in 4 to 6 hours after procedure, and antiarrhythmics drugs will be continued for 3 months. Then we'll change it. And proton pump inhibitors for 1 month. Discharge next day is follow only 3 months. So it's not going. So it in conclusion. So this is a compared to point-by-point procedure, this procedure can be as a daycare procedure. It can be done as a patient can be discharged very next day, and it is a conscious sedation procedure. and they do usually reasonably well with 85% of 90% success rate. And across the centers, across the operators' experience, we can give the predictable results we can deliver to these patients. Thank you very much for your kind attention.
Thank you, sir. So this brings to the end of this session. We'll have a short tea break and then proceed for the next session. No tea break. Any questions?
Hello. So good morning once again to all the doctors. So we have made a very slight change in our schedule. So we'll start VT session in 5 minutes, and the device and technology will happen after the words. So I requesting to all the presenters to be here, and we'll start within 5 minutes only. Thank you. Hello. So as for my words, we'll start a VD session within 5 minutes only. So I requesting Dr. Viswajit Majumdar, Dr. Arun Gopi, and Dr. Uday Sankar Das to be on stage for glorifying our session, which is will start in 5 minutes only. Thank you. Hello. So this is my request to Dr. Viswajit Majumdar, Dr. Arun Gopi, and Dr. Pradeep Hashija to get on the stage for glorifying our this session, which will be on VT. Okay. Requesting Dr. Mukund Prabhu to be in the podium and presenting his presentation. Thank you.
Good morning, esteemed dignitaries. Thank you for the opportunity as well as preponing it to adjust for my flight time. So without much ado, I will straight away go into the talk. So it's a vast topic. and I will cover under definition, clinical features and diagnostic modalities. And I'll not be covering all of them. I'll just briefly mention acute myocarditis and granulomatous myocarditis and genetic variants and non-specific inflammatory cardiomyopathies, of which we have a very poor understanding as of now. So what's an inflammatory cardiomyopathy? So it refers to a diverse group of disorders in which inflammation of the heart, so-called myocarditis, is the proximate cause of myocardial dysfunction. It may be an acute, it may be a chronic, it may be a subacute, or it may even be a chronic with acute flares on it. So it's a very heterogeneous basket of entities. And injury can range from full recoverable syndrome like in acute viral myocarditis to one that leads to chronic remodeling and dilated cardiomyopathy. So inflammation secondary to other causes like ischemia or genetic abnormalities are in general excluded under this definition. So this is an array of causes. There are broadly three categories: autoimmune, toxic, and infectious. Within the infectious, there can be viral, that's the commonest one, then parasitic, bacterial, fungal, tuberculosis, protozoa, etc., etc. Toxin is chemotherapeutic agents and other natural as well as chemical toxins. And autoimmune, eosinophilic is very prevalent in the Caucasian population. And for us, it's maybe it's not eosinophilic myocarditis, rather than endomyocardial fibrosis that is more common with us. And other causes like sarcoidosis and granulomatous myocarditis, which is not is to be excluded from today's talk, and myocardial involvement of connective tissue disorders, which are very common but subclinical many often, it's like SLE, polymyositis, and scleroderma. So pathogenesis has overlapping theories: infection, genetic predisposition. Not all patients with infections have myocardial involvement, and not all with myocardial involvement end up in dilated cardiomyopathy. Many of them fully recover. Maybe around 20 to 30% have an indolent or chronic myocardial phase, or eventually myocardial dysfunction as in DCM. And autoimmune mechanisms may be contributory. Research is going on in this direction. What factors are playing a key role in evolving into a chronic inflammatory syndrome. And many of these diagnoses have overlapping, like sarcoidosis, for example, EMF, HIV-related cardiomyopathy. And what are the clinical presentations possible? Outside the electrophysiology circles, the presentations may be acute life-threatening heart failure, as in fulminant myocarditis, with accompanying rhythm disturbances, acute heart failure presentation, acute chest wall syndrome, like angina-like syndrome, which may be thought as coronary artery disease, but subsequently labeled as MINOCA because angio was normal, but has troponin elevation as well as ECG changes. Many of them are actually viral myocarditis with or without pericardial involvement. Because we are not evaluating them routinely with a biopsy or a viral screen, as we miss this phase. Yet another presentation is chronic heart failure, commonly labeled as dilated cardiomyopathy. Ongoing inflammation is often missed unless we specifically image. And chronic heart failure with heart failure symptoms themselves, decompensated heart failure. But for electrophysiologists, they may, apart from this, may present as ventricular arrhythmia, like frequent PVCs, frank VT patient, presentation or NSVT presentation, and pleomorphism of these arrhythmias. So diagnosis is always based on combination of clinical history, ECG, blood test, cardiac imaging, and endomyocardial biopsy. Not a single test may be contributory in a given patient. Even despite doing all these tests, we don't have a clear diagnosis at the end of the evaluation. But what we have to know for sure is ECG, when to suspect this. In the given clinical setting, fractionated QRS evidence of something is not normal in the heart. There is a slowing of conduction or merger of wavefronts colliding in the QRS. BPCs, especially those with varying coupling interval. This is a diagram taken from this particular study, published 2 years back. This is actually dispersion in coupling interval, that is maximum coupling interval minus minimum coupling interval. The larger the dispersion, more likely that there is a inflammation picked up by doing a PET. Fast heart rate dependent VPCs. What this means is whenever heart rate is faster, you get more VPCs. A diurnal variation of VPCs where daytime burden is less, distinctly more often than nighttime burden. But even in this paper, the daytime burden was not exceedingly large compared to the general population, but this diurnal variation was noted, and they could statistically correlate it with the presence of inflammation in PET. Another pattern is slow heart rate dependent or the nocturnal VPC load. So whenever there is a diurnal pattern, think about possible myocardial inflammation. Whenever there is a varying coupling interval, think about myocardial inflammation. Whenever the morphology varies, it doesn't fit into an idiopathic or typical VPC morphology, but there are multiple morphologies, the so-called pleomorphic VPCs, and fractionated VPCs, broadly fractionated QRS complex during the VPC. All these scenarios, think about possible ongoing myocardial inflammation. It may not be dramatic acute myocarditis-like presentation though. Gold standard is endomyocardial biopsy with all its limitations. In all cases of giant cell myocarditis and fulminant myocarditis, where you have a dramatic heart failure presentation, just like ACS, but not due to coronary artery disease, this is probably considered as a must endocardial biopsy. Also in patients with ventricular arrhythmias or AV block with acute onset presentation, and when sarcoidosis is suspected, they regard this preferably to be done. But sensitivity of the procedure itself is highly variable. It's best for giant cell myocarditis and very poor yield in sarcoidosis and somewhere in between lymphocytic myocarditis. So in practice, we end up not doing it in most patients. So practical errors are sampling errors, patchy involvement of the disease. Some diseases involve endocardium more, others involve the epicardial more. Some are dominantly RV, where majority of them are dominantly LV. And so the sampling error means that we may miss despite the good biopsy. To avoid the sampling error, the recommended practice is at least 6 tissue pieces should be removed and immediately transferred to 2 types of analysis. One is RNA, that preserves unstable RNA, and then in a formalin for the histology studies. And the biopsy sample should be at least 2 to 3 millimeter square in size and should not contain fat, clot, or connective tissue, preferably. It's a technically complex procedure, and reporting as well needs skills. Despite doing a good biopsy, the report may not be that good unless there is a skilled pathologist available. So again, people don't do biopsy often for these reasons. And in current era, cardiac MRI has played a distinct role in evaluation of these patients, accurately assesses myocardial inflammation. Currently, the first-line modality to confirm suspected inflammatory myocardial disease, better diagnostic yield than acute myocarditis than chronic inflammatory cardiomyopathy, and also provides prognostic information like presence of remodeling, for example, ejection fraction variations, presence of fibrosis, so showing a permanent nature of the damage, temporal changes in inflammation if you repeat a serial MRI after initiating therapy. So it has it's a potentially diverse type of tool. These are the findings which we are not going to elaborate because of lack of time. So you can see many sorts of findings which correlate with at tissue level with distinct findings. It's an example from the real case example showing it's a T1 and T2 map, which shows or picks up extracellular edema is best picked up in T2 map, and T1 map suggests a myocarditis in this particular case. There's a good criteria, 2018 Lake-Lewis criteria. Sensitivity exceeds 90% with a specificity of around 68% or so, and that is regarded as a reasonably good diagnostic criteria for myocarditis. This is yet another patient. This shows late gadolinium enhancement in the infraseptal region, and T1 map also shows the same abnormality here, suggesting an acute myocarditis. Coming to PET scan, it's very sensitive for inflammation. However, it needs some preparation. Unless meticulously prepared, the results may be misleading, like dietary avoidance of particular things or heparin before the procedure, to reduce the impact of physiological uptake. No large-scale studies are available yet in this particular substrate, though we often do it. And fusing it with MRI can even be more promising, albeit expensive, similar to PET-CT, PET-MRI. This is a clinical case around 3 months ago, came with a syncope. However, unlike the usual syncope, she had fecal incontinence, and that's the reason why it was evaluated with more rigor. And ECG was showing bigeminy, I didn't include it here, and ST depressions. The angio was obviously normal, troponin was very mildly elevated. And Holter picks up these pleomorphic VPCs. There are 2 or 3 morphologies of VPCs or NSVTs, though the VPC burden is low. In view of the clinical presentation, which was not very soothing, we decided to investigate further, and this was the MRI, which showed a gadolinium enhancement in the mid-septum here. There was a patchy gadolinium enhancement, and the PET showed corresponding uptake in the same area, hotspot in the same area, suggestive of a myocardial inflammation without any lymphadenopathy. Again, we are stuck up here. We don't know what is causing the inflammation. Most of these patients, for lack of better guidelines and better tests available, end up in anti-inflammatory or immunosuppressive therapies. And that's how we approach inflammatory cardiomyopathies. I'll just briefly touch upon individual cases. Viral myocarditis, probably I will skip here. And again, the same diagnostic difficulties. It's very common than considered. 3rd leading cause of sudden death in athletes in a US registry. 16% of autopsies in less than 40 years were due to acute myocarditis. These are the patients who are apparently healthy, suddenly collapsed and died, and biopsy confirms acute myocarditis. So that sort of presentation should always be kept in mind. So these are the evolving biomarkers. Maybe in coming 10 years, we'll have better information how to use them in the diagnosis of acute myocarditis. Giant cell myocarditis, again already mentioned, fulminant presentation. Biopsy is good because we have immunosuppression response and results are reasonably good. Granulomatous myocarditis, again sarcoidosis and tuberculosis are the important causes. Sarcoidosis I have to exclude from this presentation. So this is the approach, this from the Simmons paper. So once we have a lymph node evidence of biopsy or a tubercle incident positive, we go to the TB path. Otherwise, assume it as a sarcoidosis. And this is an interesting entity, recently diagnosed, desmoplakin cardiomyopathy, previously used to be thought as ARVD, but Carvajal syndrome, where you have left ventricle dominance, sometimes cutaneous involvement as well. And episodic myocardial injury may contribute to progressive fibrosis, myocarditis-like presentations, troponin elevations, and conventional ARVC criteria perform poorly in this substrate. Mutation is actually desmoplakin, so in a such sort of presentation, probably genetic testing is useful. Phenotypic features are there in only 40-55%, woolly hair and a palmoplantar keratosis. Frequent VPCs is another hallmark. So diagnosis rely as of now on genetic study, and it has bouts of acute inflammations mimicking myocarditis as well. So this 2022 updated criteria is a bit better for picking this sort of environment, but high index of suspicion and genetic analysis should help. And finally, about treatment or immunosuppressive therapy in inflammatory cardiomyopathy. Clinical trials have shown strikingly different responses based on etiology. Immunosuppressive drugs were beneficial to the subset of population with fulminant, acute and chronic autoimmune myocarditis, whereas in viral myocarditis, rather than immunosuppression, intravenous immunoglobulins fared better. So once we have a patient with immunosuppressive therapy to be planned, like not sarcoiditis, unknown inflammation, probably steroids, azathioprine, methotrexate, as well as HCQs have been tried. This is a 2023 paper, same one which I cited a while ago. And all these drugs were tried. None were actually studied head-on, but it showed clinical reduction in ectopic burden and arrhythmias, apart from adjunctive catheter ablation. So probably one of these drugs, one or combination of these two drugs, should be the primary thing in inflammatory cardiomyopathy. And in future directions, we have different types of PETs coming, radionucleotide tagged, and that agent will change. And classification, including genetic as well as morphological phenotypic, is promising. And somewhat in the coming years, treatment may sound like this, where you have inflammatory cardiomyopathy, biopsy, imaging, biomarkers, genetics. Based on all the results, decide an individualized approach. In summary, myocardial inflammation with no other features or systemic or lymph node involvement is an incompletely understood entity. Immunosuppression is given in symptomatic patients. Future studies are necessary in this direction for better clarity. Thank you.
Thank you, Dr. Prabhu, for nice talk. Any question from the audience?
So there is no consensus. So generally steroid we give 12 weeks. Many people follow a shorter duration like 8 weeks in this substrate and reassess an image like MRI or PET. But my practice I stick on to 12 weeks itself, because we never can exclude a sarcoidosis without a biopsy, though there is a no lymph node. So I just stick on to 12 weeks.
Actually, Natsumansa's group, they actually, after the initial steroids, they continue on disease-modifying agents for quite a long time still, and they follow it up some with biomarkers. Earlier, HSCRP was more, and now they are looking at ST2 and interleukin markers, actually, and still the markers come down, steroids are there, and then they are on azathioprine or disease-modifying agents, just how you would manage a pulmonary sarcoid or not. The entire duration, nobody is exactly clear because the PET silences down after some time, and these are diseases with peaks and troughs. So the whole duration follow-up, nobody is very clear about it.
Yeah. Yeah. Yes, sir. No, without a diagnosed sarcoidosis, it's hard to decide, sir. Two papers, one which I showed, and then from Kalyan Shivakumar's group in 2022. Both of them acknowledge that there is a lack of consensus here, and no uniform protocol was used. It was titrated case-to-case basis.
So most of the things actually, it's difficult to say because the radiology people are also evolving and understanding this. So when we send them, they are reporting something, there is not correlation between what the radiologist says and where the site of the VT is also. So if you have a clear picture where the PET inflammation, the MRA edema and the site of VT corresponds, you give them therapy. One of the things that sir says is after follow-up, when the therapy is withdrawn, they flare back and come back. So that is a disease that's something beyond post-viral or toxin-related issues going on, something immunological is going on. So the majority, how they realize that itself is those typical so-called idiopathic VTs which were ablated. They coming years back after with recurrence in a different morphology pattern VT. There were all telltale signs which say that something beyond a local cause is there, and that those are the kind of patients, they will come back with different kinds of presentation. Maybe now VT, later on heart block, later on heart failure. Those kind of people are definite entities where they need lifelong therapy. The other gray zone that you said, we are all learning and we are all evolving, and we will understand things as we go on. One thing is probably now in this era, where do you actually find a place of EM biopsy for all these evaluation, or it is all going in a line of genetic plus biomarker assessment plus imaging. That would be the triad in which the current generation is going on. But the Padua criteria is all in those lines.
I have a question. In a scenario of myocarditis, with improving LV function, we know that this myocarditis is going to improve. What is the role of a device therapy, ICD, if someone is presented with
so his question is, in the myocarditis, 1/3 recover, 1/3 persist, and 1/3 worsen. So where do you place the exact role for a device? Like what point of time you decide that he requires a device?
Probably there's no correct way to do it. It should be individualized. Once you have a cardiac arrest, probably most of us will err on the side of ICD rather than a stable VT, who will keep a follow. But again, you have to individualize decision after a discussion. That's what I'm not
probably
sure.
One thing that goes favorable is once the inflammation settles down, repeat an MRI at that time when you have significant gadolinium enhancement, and their thresholds are also different actually. Like if you have some papers put it at for 15%, some put it at 10%, and the location of the scar also. Like if you are if you have subepicardial significant area, mid myocardial scars, and those things are possible predictors of future arrhythmia. And later on in follow-up, maybe EP study will have a diagnostic role to assess their risk for future risk of sudden cardiac death as well. These are all in non-recovering LV function that we're talking.
Yeah.
For everyone?
For everyone. Because he's saying that when we are giving immunosuppressive, it will take time to get.
Yes.
So we don't want to take risk. If one VF episode, the young person will go. So it's a low threshold to put ICD.
Because some cases when I'm little out of date, when we were, sir used to do PET and MRI, and some of them actually who present typically this pleomorphic subset, their PET inflammation was recovering, and if they have gotten immunosuppressive therapy early on, steroids pulsed early on, there are cases where the inflammation is totally gone off without a residual scar. So those areas, that time sir was saying conservative and we can wait and watch probably.
Because now, same question I asked, sir. They have lost 1-2 patient like this.
Okay.
So it means if we are doing everything, diagnosis made, patient lost, then what is the meaning of? So although no guidelines, but still putting ICDs. But although one patient is there, I have regular follow-up, who was put on ICD. Now totally he was okay, no shocks in last 5 years. Now what to do with the ICD? That also question raised here. And for another point, for sir is always do ketotriosidase, a new marker. So he follow ketotriosidase level, whether it's a falling, and PET for inflammation, everything to monitor the immunosuppressive therapy. Although it's a gray zone when to stop and not to stop, but still if patient is, there is scar reduced and this inflammation reduced and ketotriosidase level is coming to normal, although high sensitive C-reactive protein ESR, he's saying it's a non-specific, we are not doing, directly we are going ketotriosidase level. So although gray zone area, but still with the, if a patient is VT free, VF free, then he taper off the immunosuppressive therapy. For steroid, for short duration only. Then immunomodulators.
It's hard because in last 2 years ago, one patient was a 71-year-old, again came with syncope, did a TMT and showed a short run of very rapid NSVT. Then MRI PET pathway, again showed inflammation, put an ICD, 1 year it went well, completed 3 months of immunosuppression. 1.5 years later, he developed appropriate shock. So it's 71 years. So we never know actually, probably there's no right answer here, we have to individualize. Thank you.
Thank you. It's a good talk and a good discussion on the subject. Now we go on to the next talk. I request Mr. Dr. Anirudh Vyas. Who's the one next?
Okay, thanks Dr. Prabhu. And we're moving to our next presenter, Dr. Jayakriti Rao. So, Doctor, please. Okay, so requesting Dr. Anindya Ghosh to be on the stage and presenting his presentation.
A very good morning to all. At the outset, I would like to express my sincere thanks at having been given this opportunity to present on this topic in this prestigious forum. My topic is how to manage a patient who has a high PVC burden. The PVC being an RBBB and LPHB morphology. That means it's a left anterior fascicular PVC in a background of RBBB LAHB. So that patient has a left anterior fascicle which is diseased in sinus rhythm, and the PVC is also coming from the diseased fascicle. So there is no other history available. I did not have such a case, but I have a case where the anterior fascicle is diseased. As you can see, this is a 70-year-old patient with left anterior left axis deviations, left anterior fascicular block morphology. There is a poor R-wave progression because the patient is actually an ischemic cardiomyopathy with a moderate LV dysfunction, EF of 35%. And he has come with complaints of recurrent palpitations and presyncope. He has, this is just a schematic diagram to show that the left anterior fascicle is diseased or probably slowly conducting. And this is just the schematic, and this will come in more handy when I discuss the VT. This patient had this VT. So the morphology is, as you can see, there is an RBBB morphology. There is an RBBB morphology with a rightward axis. So this is an RBBB with LPHB morphology with a small r big S in V5, V6, and the QRS is fairly narrow. In the background of, you can still see the baseline ECG characteristic, which was an left anterior hemiblock morphology. So this tells us the exit of the PVC is from a left anterior fascicle which is diseased during sinus rhythm. So what are the, we will go into the details, but what are the etiologies of this PVC? What is the mechanism of this PVC? It's grossly irregular. You can see 380 to 370 it also goes, 360, 310 also it goes. So most likely when we talk about fascicular VTs, the mechanism is re-entry. It's a macro re-entrant circuit which has been described by Professor Nogami. It involves a slowly conducting verapamil sensitive zone, but that is in normal hearts. So when we talk about abnormal hearts, when there is already a diseased fascicle which causes a different electrophysiological characteristic compared to the other fascicle, it just becomes a favorable environment for a interfascicular re-entry. So because this patient, for this patient, there was no history provided, and there was no data on LV function provided. So I will just go on with the discussion as a patient with a PVC, high burden, how to manage, and then we'll come back to this patient again in the end. So the management determinants for a patient with a PVC, irrespective of ventricular function, depends upon symptoms, presence of underlying structural heart disease, ventricular function, whether there is a sustained ventricular arrhythmia or not. In our case, it could be interfascicular re-entry. Even a non-sustained VT is sometimes taken into account when deciding the management. Also, the life expectancy comes into play. Management options are manifold: drugs, ablation strategies, and sudden cardiac death prevention in form of a ICD. When we talk about fascicular PVCs, we rarely think about ICDs. But if there is an underlying structural heart disease, LV function is not normal, ischemia in the background, and an interfascicular re-entry, a diseased fascicle involved, definitely becomes an indication for an ICD, because in patients with interfascicular re-entry, when you ablate the diseased fascicle, that becomes an IDES for a possible bundle branch re-entry in the future that is again amenable to a sudden cardiac death. So PVCs in general are very common. They are benign and asymptomatic in most cases, but they may result in disabling symptoms, LV systolic dysfunction, and PVC-induced VF also. We are mainly discussing about fascicular PVCs today. So how do they cause cardiomyopathy or VF? They will cause insufficient ejection, aortic ejection. As previously shown, we often see bigeminies with alternate beats not conducting to the periphery, so the pulse is not felt at all in the peripheries. So therefore, and the symptoms are predominantly related to the hypercontractility in the post-compensatory pause beat, and they also lead to a short sequences, these short fascicular PVCs, which can lead to something like this, polymorphic VT or VF. So PVCs, isolated PVCs can also indicate, so you have a 24-hour monitoring, 35% PVCs, no sustained or non-sustained VT. They will not give you the true picture, because this is only a 24-hour recording. Studies have shown 14-day ambulatory ECG monitoring has more predictive value. The first day of that 14-day ambulatory ECG monitoring, in 1/3 of the patients did not even reach a clinical significant value of 10%. So all the more important to find out whether there is actually a sustained or non-sustained VT with a prolonged ambulatory ECG monitoring. So a patient, this is another unrelated patient with a structurally normal heart, at times intermittent PVCs, outflow tract morphology, but at other times there will be, without any provocation, no isopril, no induction maneuvers. At other times he'll have a non-sustained VT, and sometimes it goes into a sustained VT as well. This patient was managed with radiofrequency ablation because it's a idiopathic outflow tract. So there are challenges to ablation of PVCs. Complications can be minor, and it's not life-threatening. We have to, because when it comes to a normal LV function, patients often prefer in our setting for a medical therapy. And whenever you plan for a ablation of such a PVC, because it may involve a complex morphology, maybe LV outflow tract, summit VTs or PVCs, adequate expertise, technology and imaging data should also be present, because an apparently idiopathic PVC may be in a heart which is structurally normal on the echo, but they will show a scar, which is more often than not, and the scar burden will ultimately decide whether the patient will receive a certain cardiac death prevention or not. Also, we should know when to stop. So, when to treat patients with PVCs. We are not merely talking about ablation. We'll have to know what is the normal LV size and function at baseline, and whether there is high PVC burden or not, and what are the characteristics of those PVCs which ultimately will lead to a depressed LV function or an adverse LV remodeling in future. And in patients, the most common scenario which we see in clinical practice is a patient who comes with an LV dysfunction when PVC is also running. So whether that PVC has caused that cardiomyopathy or the cardiomyopathy has set the stage for those PVCs, that is an important question. So PVC burden, as I told you, it's a single day recording of 24 hours, a PVC burden of say 5% or 7% does not necessarily mean that the patient always has a low PVC burden. It is over a long period, preferably 14-day ambulatory ECG monitoring. They don't even talk about 7 days in large studies. So high PVC burden, it has been shown that a PVC burden of from 10 to 24%, that is the range in studies which have shown that those frequency of PVCs can actually lead to a depressed LV function in future in long-term follow-up. So and as I told you, a single 24-hour ambulatory ECG monitoring is less reliable if the first day monitoring is showing a PVC burden of less than 20%. Also, the inter-day variability. If a patient has a PVC burden on a 14-day ambulatory ECG monitoring, some day 7%, another day 35%, that is more often an indicator that has been found to be a high predictor for development of LV dysfunction in future. So I'm running short of time. That has been seen with that asymptomatic PVCs normally do good on follow-up. So there is, all said and done, there is still a low risk of progression to cardiomyopathy, so patients can be kept in follow-up as well and monitored by echo or other parameters. And as soon as they develop symptoms or LV dysfunction, the first instance you can consider a ablation or a escalation of therapy in medical therapy. So in patients with LVEF of unknown cause, whether the cardiomyopathy came first or the PVC came first, it's very difficult to find out. So is it possible to predict the success of PVC ablation, whether it will lead to an improvement in LV function in future? If yes, if there is a PVC burden which is more than 20% at baseline, and if the LV has not become so much dilated, so it is still less than 60 millimeters, and diastolic diameter, it is still likely to recover. So there is a score which Dr. Vosko-Boniek published in Heart Rhythm. They took patients, some 200 patients with PVC burden of more than 5% on the ambulatory ECG monitor and a documented echo with an LV ejection fraction at baseline less than 45%. They saw on follow-up on multivariate analysis and subsequently logistic regression, that PVC burden more than 20% in coupling, more longer coupling interval and non-sustained VT had a higher predictive risk of adverse events. The adverse event being LV decline, LV ejection fraction decline by 10%, heart failure hospitalization, and cardiovascular mortality. They say on a PVC which has a superior axis, which is coming from the apex, anything which comes from the apex or an inferior direction will lead to more LV dysynchrony. So probably leading to more risk of LV dysfunction in future. So the burden, if the burden is more than 20%, they've given 3 points. Coupling interval more than 500 milliseconds, 4 points. We have to understand that people think a short coupled PVC may be more dangerous. Yes, it can be more dangerous, but the one which is a longer coupled is more likely to result in cardiomyopathy because that causes more dysynchrony, that causes less LV filling time for the next post-pause beat. And if there is an NSVT, that is also high risk for development of LV dysfunction. So based on the scoring, they said score less than 2 is low risk. It is written 0 to 4, but less than 2 is low risk, and anything above 5 can be considered amenable for a intervention. So there are patients where we can calculate the score. Although it is not possible, it is not correct to calculate the score in our patient already has a severe LV dysfunction. But if you just go through it, the axis is inferior, 0 points, the burden is 35, 3 points, coupling interval 0 point, but NSVT 4 points, so it's a intermediate risk score. PVCs from left fascicle, posterior fascicle can also lead, any fascicle, his Purkinje system can lead to VF. This in contrast to the other fascicular PVCs will appear similar in morphology, but the mechanism is different. This is enhanced automaticity, that is a re-entry. These are short coupled and often lead to polymorphic VT and VF, predominantly in the setting of a structurally abnormal heart. So you cannot say, even if structurally idiopathic hearts, fascicular VT is a re-entry. In a structurally abnormal heart, it can be a interfascicular re-entry in tachycardia, or in the setting of an ischemic cardiomyopathy, it can still be an enhanced automaticity, as in this case, which can be treated by ablation. So I'll just run through fast. So again, there are some other examples of this. This is an example of a patient who has a normal ECG in baseline, maybe poor RV progression because of an old anterior wall MI, but has a PVC which is left posterior fascicular morphology, RBVB, LAHB morphology. This patient has a VT of the other morphology. This is RBVB and a rightward axis. So the PVC was coming from the left posterior fascicle. Now during the VT, it is left anterior fascicular VT, or a pap muscle VT, if you can say, because it is very difficult to differentiate sometimes with a papillary muscle VT from a fascicular VT. Papillary muscle VT can also have a narrowish morphology because all those his Purkinje network is actually housed inside a pap muscle. So how do you treat it? You just, there is something called point density exclusion. You can create a map, get the earliest point, and at a site which is like 50 milliseconds early in this case, you can just give a burn and ablate. So at 6 months, there is no halter PVCs. So in summary, PVC management in isolation is should be discreet, and decision should be shared with the patient. In a structurally abnormal heart, it is not much of an issue to decide. You will have to intervene in some way or the other. In an asymptomatic normal heart, low PVC burden, that burden being decided on a prolonged ambulatory ECG monitoring, sit quiet. And drugs do have a limited role. And RFA, only when you have the adequate expertise, should be done, because it certainly poses some risks, particularly in idiopathic PVCs of the outflow tract variety, and less often with the pap muscle actually. So with this, I'll end my topics. Thank
you. Very nice coverage on VPBs. I have one question. If the patient has only VPBs which are more than 20% and other scores are 0, so that means total score becomes 0. I mean, total score becomes 2.
Sir. Yes, so sir, actually, the patient has that score is in a patient who has more than 5% PVCs and LVF less than 45%. So he has PVCs. If the score is low, you can just.
No, my question is other way. PVC burden is high.
You can still wait, sir, because you don't
because
have.
20% has been given as cutoff in most of the studies. Some have even said that 14% and above. Yes. And 10%, as you said, this score is 1, and 20% and above score is 2.
Yes, sir.
So if he has 30 or 40% VPVs, then scores will be remains 2 only.
Yes, sir.
So do you subject them for any ablation, or you just
no,
keep
sir, actually,
watching?
in that same paper, their introduction was like, there have been studies in the past which have shown that patients with PVC burden of 7% also may lead to cardiomyopathy, and more than 30% also may be totally asymptomatic with no change in LV ejection fraction or no LV remodeling. That is because the kind of PVC also matters. They are talking about a PVC with superior axis. If it is a PVC, for example, outflow tract PVC in your case, that leads to less dyssynchrony because it's mostly from the midline. Outflow tract is a midline structure, and doesn't lead to so much dyssynchrony as compared to an inferior origin PVC which is coming up. It is intuitively, and there are PVCs which are away from the septum. Those will lead to more dyssynchrony and more risk of adverse LV remodeling, leading to VTs and adverse outcomes.
That is very well covered in your scoring system. I am talking about PVCs from any RVPCs.
30% burden,
Yeah.
normal LV.
Patient with the patient.
How long do you wait? That is
Sir,
the question.
if the patient is asymptomatic, truly asymptomatic, we'll tell the patient it's his choice. He may just he may be very well informed, and he may just say that I want to get rid of this PVCs and I don't want any risk of a adverse event in future, or else we'll give him an option. We'll follow him up every 6 months. We'll look for evidence of symptoms. We'll look for any evidence of an LV dysfunction, any sustained VT or non-sustained VT on a prolonged ambulatory ECG monitoring. Only then the decision for a further intervention will be decided. Because otherwise there is no point, because there is no endpoint. Patient is asymptomatic to begin with, and if you don't give him, and if you do a procedure,
there is always a risk of developing LV dysfunction.
This patient has equals apparently normal. He will do MRI, do standard structurally normal.
Yes, sir.
20% burden.
Yes.
Because majority time we are doing equally normal
Sir.
follow-up.
Sir.
It is better to use
Even the guidelines cover, and I think gives up to 20%. Beyond that, you should take them up because there is more risk of LV dysfunction after that. Follow-up is obviously there,
but it's
that is a slightly grey area still. I mean, people with asymptomatic VPVs.
Sir. Okay, sir.
I have not done MRI that time. Now you do MRI, there are some scars, something like that. It may happen because of the primary pathology which is causing DPC. That is also
True, sir.
responsible
True, sir.
for dysfunction. Another maybe it is really structurally normal heart because of PVC. So
Sir.
these two entities are different.
Yes.
So CMRI has a role.
Yes, sir. Definitely, if you think the PVC is not that typical kind, little atypical feature, little more broad, then you do a MRI, sir. Then it will help. Just this.
Your understanding of structurally normal heart is evolving over time. You don't know what defines how much imaging you require, how much evaluation you require. So just one question. It might be looking as to a foolish question, but how does a conduction system PVC, like an PVC that you showed, whatever be the burden, how should it cause an LV dysfunction when you're doing as a conduction system pacing as a treatment for resynchronization?
So, a conduction system PVC is less likely to cause LV
Yeah, less
dysfunction.
likely. Even then, why would it ever cause? Because you are doing if this patient, you take him to the lab, you don't have a CS, you might even do a conduction system pacing. You might do a fascicular pacing or anterior fascicular, posterior fascicular pacing and say that this is a response for recovery of LV function.
Okay, sir.
On the long term.
Yes, sir.
So when you have conduction system pacing on one side, recovering LV function, how would you ever think that a conduction system PVC?
Sir, it is as you told correctly only. It less likely, but how will it still cause it? Is if it is coming from away from the septum, like an anterolateral fascicle, anterolateral pap muscle, that is away from the septum, that will cause more dyssynchrony. That is only one possible way I can think of it causing a LV dysfunction. Otherwise, it is still not a physiologic cardiac activation. It is coming from the fascicle, maybe a little more distal. There will be always dyssynchrony when it comes to RV activation. RV activation will be delayed. Dr. Shanmugasundaram's paper is also coming because he has found out even if you miss conduction system pacing and it is ultimately an LV septal pacing, there is also a risk of pacing induced cardiomyopathy from left bundle area pacing itself. So maybe away from the septum, that is one mechanism. It will cause more dyssynchrony, sir.
So a couple of points just I want to add with permission of chair.
Yes.
Very nice, fantastic talk by Dr. Aninda. So what I feel, what Dr. Gopi wanted to allude actually, so as he mentioned that in order to achieve that conduction system pacing, we are often getting that fascicular PVC only in place of ventricular apical pacing, right? So, and that is sometimes good enough or gratifying to get rid of some LV dysfunction component. On the other hand, it is not unusual to see that a person who is already having some, kind of bundle branch block in the form of RBAB with LAHB or the other way around. So sometimes they are having lot of PVC burden, and at the same time they are developing some, LV dysfunction. So I think the substrate is something different. We are not actually dealing with the same substrate that we are talking about in presence of narrow QRS, ECG, baseline ECG. So there must have been some kind of inflammation either in the form of granulomatous or maybe as a part of degeneration that we are dealing. But when we are talking about the management, so in that respect, I think when we are talking about the ablation part especially, so I think what I understood from this particular topic, so probably we are trying to potentially harm the bundle, which are actually the surviving bundle from where the actually PVCs are coming. If in a given context, you are getting right bundle branch block with left anterior fascicular block, and if your PVC morphology is essentially having RBAB with LPHB, yes, so probably you are handling the surviving bundle. Then probably you are in a big soup to go for the ablation with a very aggressive way. So you have to be, kind of introspective much more. I think Gopi sir must.
Sir, it's like, sir, sorry. Yeah, that's what, it's a quite a valid discussion which is elaborated on. If you have a posterior fascicle which is surviving in this patient and that itself is showing you VPBs, do you go for ablation?
No, sir. It was coming from left anterior fascicle, sir, and the disease fascicle was left anterior fascicle only. So there is not much doubt in this case because in interfascicular re-entry, you target the diseased fascicle first, sir. If you are not successful, then if we handle the, as you said, LPHB, then the patient is just asking for a dual chamber ICD or a CRTD.
Thank you. That's a lovely talk. Good. So we call upon the next speaker. He is Dr. T.R. Muralidharan, if I'm not mistaken. Who's as per the list?
Okay. So thanks to Dr. Ghosh. What a wonderful presentation it was. So may I make a request to all the guests, because as per the rule we have to leave the rooms, check out the rooms by 12. Not the rooms, hotel rooms only, not the conference room. Okay, so I'm requesting our next speaker, Dr. Jayakriti Rao, to be inside the.
So I'll vacate the room after the talk, right? Yeah, hopefully. Thank you, chairpersons, and thank you for the organizers for giving me this opportunity to be in front of you all. And it's a wonderful meeting. Thanks, Suchit and co. The topic for me today is parahesian ventricular tachycardia. Well, I've had only PVCs that I'll be showing. And I work in Burjeel Hospital in Abu Dhabi. A definition of parahesian PVCs, those in which the earliest activation is recorded in the presence of a His bundle, His potential, or within 10 millimeter distance from the His cloud. Most idiopathic non-reentrant VT and PVCs arise from the right or the left outflow tract regions, and 3 to 9% of all idiopathic ventricular arrhythmias arise from the parahesian area. As to etiology, most are idiopathic, and patients on occasion with cardiomyopathies or scar-related VT may exhibit septal arrhythmogenic substrate involving the parahesian region. There's an important diagram to remember that, this is where the His bundle runs, as we all know, as EPs, and then the nearby structures are the right and the non-coronary cusp, and this is important that we map all the surrounding structures to know the focus. So the presence of the His bundle, which is more posterior and rightward, results in a leftward shift of the vector, which in turn result in specific ECG findings, like a tall R and a monophasic R wave in lead 1, lower amplitude of R wave in lead 3, and a presence of R wave in AVL. So we'll look into these findings, and as per the year of recognition of these specific findings, I have taken the slides to be. It was initially during formation of this ECG algorithm for outflow tract arrhythmias by Ito et al. they described a presence of RSR prime or RR prime in AVL to suggest a perihesian uh, PVC or a VTAC. And this is an example of this finding. And in 2005, this was a large series which described specific findings, where they found monophasic R wave in lead 1 was seen in all patients with parahesian PVCs compared to RVOTs. And these are the diagrams. On the left panel is the parahesian. These are the right ventricular outflow tract, non-parahesian regions. And any R wave in AVL was seen in 2/3 of patients with PHPVCs. A QS pattern in lead 1 and a transition zone which was early before V3 was seen in 80% of patients. They also noted that the QRS duration is shorter in compared to RVOT. This is because of early engagement of the His-Purkinje system. And they also noticed that the R wave amplitude in lead 2 was, in lead 3 was significantly less compared to lead 2. This will later be described as a R wave in 2/3 ratio, etc. And this was in 2014, where they showed this R wave ratio in lead 2/3 was significantly higher in parahesian PVCs, with the ratio being around 4. Okay, this has not been consistent, but overall, as a group of findings, when we take things fall into place. Then there is another characteristic, inferior lead discordance. Inferior lead discordance can be positive negative, as shown in this, or it can be negative positive. If it's a negative positive discordance, we know it's anterolateral pap muscle area. For positive negative, we have two differentials. One is parahesian ventricular arrhythmia, and the other is RV moderator band VAs. And how do we differentiate? RV moderator band VAs, as was discussed earlier also, the farther away from the septum you go, the broader the QRS gets. There is notching in the inferior leads. There's very late transition in the precordial leads. Then when it comes to management, this was learning before burning. This is how, this was an editorial by Professor Ho. The electrophysiologist is faced with a delicate balance between the wish for success and an equally strong desire to avoid AV block. And this cannot be more true than this situation or location of the PVCs. We have to take some precautions to avoid collateral damage. As was discussed just now, medications first, ablation next, and choosing the right candidates, people with LV dysfunction, people with very high burden, people intolerant to medications, and syncope. These are the candidates for ablation. And we have to reach an area where the His deflection is the smallest, yet not compromising on the precocity compared to the PVC onset. And we have to try to burn in an area where the His bundle is not more than 1 millimeter in height. We have to be as distal as possible, preferably more than 5 millimeters away from the His cloud. We have to reach an area where the AV ratio is less than 1. And we have to look for a QS to succeed. That means you are at the dot and not somewhere surrounding and increasing the ablation points and causing the risk of AV block. Gradually increase the power, starting if you are using an irrigated catheter, probably with 15 watts. And this is the low and slow approach. I'm just quoting some of the names that have been quoted in the articles. Then a detailed mapping, including a 3D if needed. What does detailed mapping mean? RV and LV septum, right and non-coronary cusps, and the contiguous RA plan. And we'll just touch upon some of these approaches. This is an area, this is a case where the precocity was about 40 milliseconds. But if you see the mapping distal, there is a significantly large His potential. And the AV ratio is not significantly big. And the mapping distal does not have a big V. So these are important things we need to look into. So the catheter was moved a little more distally. We compromised, it was only 35 or 32, and then we ablated because the His signal is quite small. And it's very important to search for the neighboring structures. This was published in 2008, where His bundle signals were very interesting, everything fused and very early, and ablation likewise was 25 milliseconds early. But when they ablated there, they realized there was a decrement and delay of the local potential on the His catheter. The local potential, in fact, was well within the QRS. So there was a far field potential that was detected, and then moved to the non-coronary cusp, where they found the near field signal and ablated successfully. So there are some features which tell us whether we'll be successful or how is the success rate. And R by S in lead 3 is one such feature. An RS ratio of less than 1.1 showed a success of 99%. Whereas when it is more than 1.1 in a single lead feature, this is interesting. If it is more than 1.1, the success rate dropped to 55. That's half of it. So an RS, why was it so? An RS ratio in lead 3 of more than 1.2 predicted less than 5 millimeter proximity of VA origin to the largest His potential. So probably hesitant burns and inadequate burns, etc., resulted in lesser success. But interestingly, in this article, they gave away one important point. The terminal R wave in this article showed that the focus is likely left parahesian. So a QS was already shown to be right parahesian, and a terminal R pointed to left parahesian. So this is a case where we see the terminal R quite prominently. And this also depicts how important it is to map all the structures, right atrium, left, and the cusps. And it's also important that we have catheter stability in these critical areas, especially on the left side where the His is quite superficial and AV block is easy to get. And curved approach may be one of the approaches to keep the catheter steady. And a good pace map is very helpful. You may not get it at sites, but if you get it, it really helps. And this is what I alluded to in the earlier earlier slide. Ablation signals are very important. You should have a very large V, AV ratio more than 1. And also, the proximal ablation should have a V signal to be away from the proximal His. And look for a site with a QS, as is shown here, to be focal. There are some difficulties we face in ablation, which can be both anatomical and technical. The His bundle, as we all know, can sometimes be naked. About 20% of the time, they don't have a muzzle coat, and that increases the risk of conduction system injury. And also, we should remember that the membranous septum, which holds the penetrating His bundle inside, is partly made up of the septal and the anterior tricuspid commissure on the right. And the septal leaflet of the tricuspid valve completely covers the crest of the interventricular muscular septum, which is commonly the site of origin of parahesian PVCs. So the movement of the leaflet might cause displacement of the catheter tip, leading to poor catheter contact and catheter instability. And also, when we try to burn above the valve, we have something called the shield effect, where the energy may not be delivered well to the deeper structures. So there came the below leaflet ablation technique. This is accomplished by catheter inversion or reversion or reverse C-curve, whatever, these are all semantics, and it increased the success rate to 90%. And how do we confirm that we are below the valve? We need to, under fluoroscopy, pull the catheter, and you can feel that it is stuck there. And it can also be confirmed by an ICE catheter if you are using it. It helps for better catheter tip tissue contact, more efficient energy delivery, and less risk of AV block. This is the pictorial depiction. You're under the valve here, and on ICE you can see that you're behind the septal tricuspid leaflet. And this is another way. However your catheter appears, it does not matter. Large curve, small curve, and ultimately goal is to get in there. 3D mapping definitely helps us to delineate the His bundle region and to stay away from the critical areas. What else can we do to enhance the safety? Ablation should be avoided in the proximal His bundle area. But how do we recognize the proximal His bundle? When the AV ratio is in the range of 1, 1.2 with a His bundle, you know it's dangerous to be around there. And presence of His and atrial potential on the distal ablation bipole. Presence of a ventricular potential on a proximal bipole is important to say that you are distal. And cryoablation in future. The catheter is a little stiff. Availability is a problem, but it gives a lot of stability. You can check whether you cause an AV block or not by going to -30. But the problem is when you go for a full freeze of -70, there's a large ice formed, and you should be careful that it does not lead to a problem. And focal PFA in future could be. So when to stop ablation? At the first sign of accelerated junctional beats, at the first sign of AV block, and don't burn beyond 1.5 to 2 minutes of ablation at the successful sites. So overall, I'll take a few more seconds. Outcomes, it's reasonably good, 70 to 90%. Success rate has been achieved. Early recurrence is a little higher, but acceptable still, 5 to 10%. Complete AV block, including the transient ones in 0 to 6%, but 2% need a pacemaker. Right bundle branch again in 1 to 2%. This was one abstract that I could lay my hands on, where they showed a significant 85% improvement in ejection fraction post ablation of these PVCs. So though they are relatively narrow, they do cause PVC-induced cardiomyopathy. And thank you very much for your patient hearing.
Very nice talk. I think most of the things are covered. I just wanted to ask you about the power settings while you are ablating. You've not mentioned anything regarding how much you should avoid going to the high power and
most
how to
often
start.
we use, yes sir, absolutely. I did mention briefly in one of my slides, start low and go slow, and every 10-15 seconds you can increase the power, but we don't go like other areas which is away from the his area to 40-50 watts. We don't. By 30 watts most often we can get rid of them, but irrigated catheters start with 15 or 20. I start with 20, but literature says 15. And yeah, we have to be a little slow, yes. And I feel irrigated is better in these locations, yes.
Yeah, wonderful talk. You summarized everything in a short time. So just two things. Does an IJV approach give a better approach for the reverse C? And the second question was, when you use cryo mapping, the cryo mapping will obviously say whether it's a good spot or not, but the ice ball that you said has an additional advantage that it will ensure dead stability. Once you form the ice, it is not going to move, it is going to give you good stability. So that way freezer is better for all these parahysine areas.
Yes, it's a trade-off. In fact, my experience with cryo has been for antiseptal pathways. Not in this here, burning is, I think, a little better in the long term. Yeah. And thanks for the words also. Thank you. Yeah.
Any questions from the audience? I think your talk was very well explanatory. It's covered almost every aspect. So nice talk. So we have one more talk in this session, 12 lead ECG localization of VT localization. 12 lead ECG for VT localization. We have Dr. Sanjeev Kathuria to deliver that talk.
Thank you. So I'm going to straight away start my talk. So it's one of the areas which is very interesting, and at the same time you have a 90 to 95% accuracy provided you are able to know your anatomy well. So this is just a classification, idiopathic VTs. Our focus is the LVOT and the RVOT. What is the basic principle which governs whether you are from the RVOT or LV side? Left ventricular free wall will show a right bundle branch block, very simple. A left will come either from the right ventricle or the septum, important point. Septal exits are going to be narrower. Basals are going to have positive concordance, apical and negative concordance. And QRS axis varies with exit shifts. Now this is the most important thing which leads to our accuracy being 95. Because if the shifts occur in the exit blocks, then exits, that means we'll have a change in the morphology, we might not be able to pace map. So LV or RV origin, very simple, LVB or an RBB. So now this is the most basic slide. See, you have to divide your heart into two parts which will help us localize, because it's the lead 1 and V1 which helps us maximally to localize in the outflow tract, whether in the right side or the left side. So this really tells us the aortomyoidal continuity, the LV summit area, the left cusp or on the left side. The anterior RVOT or is on the left side, and the right cusp, the RCC, the NCC and the postoseptal RVOT all on the left side, on the right side. So this is the basic relation. This is the diagram we need to understand. So your RVOT, the posterior RVOT, is very near to the RCC. So these are the structures which are going to go a little posterior, though they are going to be, the most anterior is going to be the anterior RVOT, and then we're going to have the RCC, and then we're going to have the LCC. So as we stay anterior, your lead V1 is going to be negative. And as we go posterior, your lead V1 is going to become positive. So in a nutshell, this slide explains everything. So free wall RVOT, that means you're on the anterior side. As you say anterior, your transition is going to become late. As you say posterior, transition early. So two basic principles. Posterior, transition early. Posterior, you're going to have more of a right bundle branch block. So RV free wall will have a transition late, septal will have a transition little earlier, RCC further earlier, LCC most early because it is the most posterior structure. So you see it in the other way. LCC posterior V1, V2 transition, RCC little anterior, V2, V3, septal, and then the anterior RVOT comes. At the same time, this we all know the notching in the inferior leads because of a free wall. Anterior posterior RVOT is very, very important. This is very, because LCC, RCC you are able to understand because you are able to appreciate the LBB and the RBB pattern. Anterior posterior RVOT is a little difficult thing because posterior RVOT is to the right side and an anterior structure. It will have a LBB with a lead 1 positive. While anterior RVOT more towards the free wall is going to have a lead 1 negative with a LBB. So this is the most important difference. So understand, we'll have to go from LCC to the RCC to the posterior RVOT and the anterior RVOT. You're going posteriorly, anterior and towards the left. Suprapulmonary wall means above the pulmonary wall. The basic feature is you're going to have more 2-3 AVF becoming more positive with the same features of AVR, AVL negative and a lead 1 which is practically QS. Once again, this is an example, this is a diagram to explain the same thing. Posteroseptal of RVOT aspect of the RVOT is adjacent to the RCC, while the anteroseptal, the anterofree wall is more anterior, away from the RCC as the most anterior structure. Now this is a very classic, very good slide which can make you understand everything. V1, we have pointed, anterior most structure, anterior RVOT. You have a typical LBB pattern. You go a little posterior towards the posterior RVOT and the RCC. You still have a lead 1 which is showing an LBB. But as you go down into the left corner LCC as well as the iotomodal continuity, you will start having an R wave which is positive in V1. So posterior to anterior R wave positivity goes from a positive R wave to a negative R wave. Now if you see this in a diagram form, again, aorta is a right and posterior structure. So aorta is behind, it's the sternum is the anterior-most structure. You see aorta is behind, the pulmonary artery is in front, but you see the one part of pulmonary artery is the posterior part. The septum is more posteriorly placed. And then as you go towards the free wall, the 3 is the anterior part. So this is the structure which is to be explained if you want to understand the anatomy. But again, the caveat is that they are so close structures that you can have multiple exit points. And if you have multiple exit points, you can have the ECG focus and exit point being different. So that is why the role ECG will help you localize in 95% of cases. But in an EP lab, you can have a difference in the site because there can be multiple exit sites. So that was about the RVOT. If you go to the LVOT, most important thing is if it's a basal LVOT, either the mitral annulus or the iotomodal continuity. On the left side, you have the aortic cusp in which you can have LCC, RCC, right-left junction. LCC, as I said, is a structure which on the left side more, you'll have a lead 1 which is negative, while an RCC will have a lead 1 which is positive. LCC, RCC junction can have both the things. Most important, a sudden transition in V3 is characteristic. If you go above the cusp to the LV summit, you see the MDI. In the MDI, it's again the AVR, AVL, S ratio. Accessible, inaccessible, I'll give a diagram for that. As you stay accessible, your AVL, AVR ratio becomes higher. The negativity in AVL becomes more because accessible is more towards the midline, inaccessible is towards the lateral side. So why do we have, first of all, why do we have arrhythmias from the aortic wall? Because there are crescent of fibers of the ventricular myocardium which extend upwards. But they are mostly from the RCC and LCC, not from the NCC, because the NCC is composed of more of fibrous tissue. So tachycardias arise, ventricular tachycardias arising from the NCC are very rare. We have more of atrial tachycardias arising from that. This is the transition ratio. One of the most important things are, as I said, most posterior the structure, more the transition will become earlier. So in a LCC, in left side, you will have transitions which are earlier from the right side. And this is the ratio formula which is being used comparing the R wave which comes in the sinus or compared to the R wave which comes in the sinus and the tachycardia. Again, the same thing. Now, this is a characteristic LVOT. I'll tell you why. You can appreciate in the arrow. You have a lead 1 which is negative. See the lead V1. It has become a little positive. There are two things in the V1, R wave of V1. The width, means the length, as well as the height. Height more than 30% amplitude of QRS and width more than 40%. These two things are characteristic. This is the way you ablate in an LCC. Again, an example to show you the structure. where the LCC, how is it related? You keep on going from antral side to anterolateral side to the lateral side. LCC VT very easily identifiable, lead 1 negative, AVR AVL negative, 2 3 AVF positive. You have a V1 which will start showing a little R wave. We have examples, I'll have examples in the end. This is the site to ablate an LCC. This is more of a fluoroscopic thing. The left coronary cusp, as you can appreciate, is very near. Now, people are very afraid you are ablating in the LCC, that you are near the left vein. No. You are near the left vein, you are in the accessible or the inaccessible area. In fact, in the inaccessible area. Because the inaccessible area is near the left vein, where the great cardiac vein cuts the L6 and the LED towards the accessible and the accessible areas. Now, this is where I said you have the focus in the LCC, but the pace map, see the pace map score, more coinciding with the RVOT rather than the LCC. This is because you have multiple exit sites. So this can be the dissociation between a PAC and the pacing morphology, because the exit site is different. This is the only caveat of the QRS morphology, ECG helping you to diagnose an OTVT. Now, right coronary cusp, once again, you will have lead V1, which is completely LBV, 2 3 AVF positive, AVR AVL negative. Transition which is late. See the transition occurring V4. So I've just compared these two. Once again, just see right coronary cusps. You have a complete LBB, while in the left you start R wave starts appearing. Right coronary cusp, this is the way to localize in an LCC. In a LO view, you are able to see the RCC, NCC and the LCC differently, while in an RIO view, you'll have the RCC and the LCC overlapping and the NCC towards the septum. This is more of, not of an ECG, but more of a diagnosis of a fluoroscopy. Now this ECG I've kept just for telling that the LCC-RC junction has an abrupt transition, much better a transition. So localizing them in this area, important, no R wave towards the right side. You start having an R wave towards the left side. You have a transition which is early. At V3 exactly, you have LCC-RC junction. This is the diagram we're talking about. NCC, RCC well defined, but an RCC and LCC overlapping. And RCC and NCC overlapping themselves in an LO view. This is the problem, multiple exit sites. So this will remain a problem even while doing EP. So you'll have to just pay map and diagnose. LV ostium, this is the LV summit area. In short, this is the diagram I'm talking about. The anterior cardiac vein, the great cardiac vein dividing the left vein into, the left vein divides into L6 RCA. Where this vein cuts these two arteries is the inaccessible, and the accessible is on the other side. MDI is the one which you use for it, which I mentioned in the chart also. MDI is the maximum deflection index. If it is more than 55, these are places where you will start thinking of a inaccessible or accessible. Once again, see the diagram. You can see an arrow. This is the vein which is transecting the L6 from the left vein, LED L6 into two parts. The left one towards the left vein is the inaccessible, and the towards the right is the accessible. This is again fluoroscopy to show you the same. Accessible area is the one which is more lateral, away from the left vein, more chances that you're not going to hit the left vein. Again, this is an example of one of the cases which we did. You see the pre-potential is so early that we have 26 milliseconds earlier than the surface QRS, we were able to ablate it. Accessible areas, again, you can have an endocardial approach. Accessible, you can do much more with an endocardial approach. Another example of the same, but epicardial approach is sometimes required because you're too close to left vein. Then in this case, you'll have to really take your catheter, correlate with the fluoroscopically and then get to the area. Last area, atriomitral continuity. Characteristic feature. Once again, since it's on the left side, you'll start having an R, but you'll have a characteristic QR pattern. And sometimes you can have a reverse pattern break. That means V1 will have a R, QR, V2 will have a smaller R, V3 will have a bigger R. That's known as a reverse pattern break. V2R being smaller than the V3R. So these are all fluoroscopic correlations. In short, in end, these all are having a left bundle. You're seeing that the V1 is, the lead one is positive in an RCC, while negative in an LCC. LCC-RC junction, V3 transition. Important in these three. If you just compare the septal sites with an AMC, most important thing, QR pattern. If you see the ECG having a QR with a reverse pattern break, almost characteristic of AMC. Some examples. Here you can see they have a LBB pattern. You have a lead one which is positive. You have a transition which is late. So characteristically a positive septal RVT. Most common site. Then in this case you have a lead one which is negative. Same pattern, the late transition, that is anterior RVT. I'll just take two more slides. Then in this you have 2-3 areas massively positive. Same pattern, towards the suprapulnic site. LCC, once again V1 having an R wave. You are having a lead one which is negative, 2, 3 A wave positive. An RCC, you see the lead one is positive and you have a QS pattern in lead V1. Now this is an interesting one. The MDI is not so high, so it's an endocardial summit area. But what you can see in this is, you have a lead one negative, 2, 3 A wave positive. You have a V1 which is positive. But what you need to see in accessible or inaccessible is the AVR-AVL ratio. As the AVL-AVR ratio becomes higher, means S maybe in AVL becomes more, you have to go towards the inaccessible side, because it's gone more left. So conclusion, ECG helps to localize site in the outflow tracts quite accurately. Multiple exit sites are a limiting factor. 3D during ablation is of huge help with an activation map. And satisfactory success rates puts up a positive impetus to us in our efforts to ablate the OTVTs. Thank you.
It was an excellent depiction of, pre-localizing the site before you go into the lab for ablation. So very elegantly demonstrated, and I like the examples which you covered later on to re-emphasize your
They were
talk.
the most common ones which we see. The
Yeah.
postoseptal, very, very common.
Yeah.
Entro, less common. Then we see the RCCLC, equally common.
Yeah.
So I just put the 5 basic ones.
Yeah, and even the table was very nice, which you
Yeah,
showed.
but that
what is
table,
it
I just wanted to
actually
emphasize
different.
one point which you can see to diagnose, like a reverse pattern with QR. You are sure you are on the iotomodal continuity.
Thank you. Excellent talk.
So we had a wonderful session with excellent talk. So we'll close this session and we'll have the next session, Rakesh. Thank you.
Hello. So we're moving to our next session, device and technology. Requesting Dr. Sanjeev Kathodia to be in dais as a panelist, and Dr. Mainak Mukherjee to chairpersoning this session. Thank you.
Good morning. It's a nice morning. And now for the next 2 sessions, we are going to have a good discussion on the different parts of the device. I think the first speaker is Mr. Govind. He will be talking on the leads. Mr. Govind, chair is all yours.
Good morning, everyone. Thank you, chairs, for your kind invite and introduction. And at the outset, I would like to thank the organizers for giving industry an opportunity to make a short presentation and giving me the same opportunity. And my topic today is evolution of CIED leads technology and its design. It all began with the first implantable pacemaker in 1958, which was an epicardial implantation, the history of which is already known to you. Let me pick up a pointer. Sorry, yeah. So the history of this is known to you. Because of that, so I'll straight shift to the lead because that's the topic. So the first lead was a twisted stainless steel wire, which was insulated with a polyethylene insulation. And then at the distal end of the lead, there were a small steel disc, 2 discs, one for each pole, cathode and anode, and that has to be sutured onto the epicardial surface. And then this lead was fused with the pacemaker electronics inside the mold that they created, famously with araldite, with a QE polish shoe cans. That's what they did. So the lead had a permanent connection. So at the end of the battery depletion, when replacement had to be done, the entire system, including the lead, has to be changed. So that was the first implant that took place. The history of that is known to you. This was in Sweden. Simultaneously, in the United States, efforts were going on for developing a similar system that succeeded in 1959 with the first implant in the United States. And that lead was created by the surgeon, Dr. Samuel Hunter, and the Medtronic engineer, Norman Roth. This is a bipolar lead. This was called as a Hunter-Roth bipolar electrode. And this also had a stainless steel conductor coil wire. This was insulated with silicone rubber. And this also was fused along with the pacemaker. And the entire pacemaker itself was fused in the silicone rubber can. And then at the distal end of that, if you see here, there are two stainless steel pins that are projecting out of a silicone pad. The silicone pad has holes for suturing the lead onto the epicardium. So this was the first myocardial lead because this pin had to be stabbed into the myocardium. So this was all working all right. But then they observed a problem, which was significant increase in threshold rise that was found to be because of oxidization of the steel electrodes that go into the myocardium, resulting in a rise of the threshold and then ultimately resulting in exit block. So effort was going on for developing some lead that will minimize this kind of exit block. So when they tried to experiment with a lot of things, platinum electrodes came as a more acceptable one. So they came with a platinum conductor and a platinum wire at the end of the tip. You can see it's a continuation of the conductor wire itself, and which has to be stabbed or screwed into the myocardium. So initially it was a unipolar lead that was developed, and the insulation itself is silicone, and then later on bipolar electrodes came into that. So this was the first electrode where they could remove the lead and then connect it to a new generator. So the first removable pin was developed around this time, and initially it was unipolar, later on it's a bipolar, platinum electrodes. And then several iterations later, by 1981, stab-in platinum electrode based leads were developed, and a few iterations later we have a precursor of the current 5071 lead, which is currently normally used for the myocardial implantation. This is around the time when the first conductor alloy, which is a super alloy, which is designated as MP35N, came to be used. So this alloy is a alloy combination of nickel, cobalt, chromium, and molybdenum with additional metal electrodes, elements also. So that was a significant development in the lead conductor element development. So this had a very low resistance, and this was able to carry the electrons and charge very well. And then around this time, and this was the other myocardial lead that was developed, and around this time parallel development happened for epicardial leads, and epicardial leads which platinum electrodes was developed. Initially it was unipolar, later on bipolar. So you can see two button type of leads electrodes in this. The surgeon will have to suture this onto the epicardial surface, popularly used for atrial applications, because you cannot screw such a screw-in lead into the atrial myocardium, and also preferentially used in pediatric applications very often, particularly in the atrium. So that was the development of the myocardial leads that came about. So while all this was going on, there was simultaneous desire for minimally invasive pacemaker implantation approach through the transvenous way, and that need led to the development of the endocardial leads. The first lead was developed and used in 1959. This lead itself was developed by Dr. Seymour Furman. So the lead conductor is once again stainless steel in a polyester braided core. The insulation itself is polyethylene insulation, and the tip that goes into the myocardium or the endocardium is a large one compared to what it is today. As you can see here, it's about 100 square millimeter, pretty large cylindrical electrode, but in comparison to what you see today, it's anywhere between 3 square mm to 6 square mm different types of leads that are available. So a fairly large electrode. That was the first endocardial electrode. Then there were further developments that were happening. Most of that was stainless steel conductor wire At this time, the MP35N has not come in. So there was a development of unipolar and then corresponding bipolar. And the other thing that you would notice here, there is no fixation mechanism available. So it has to be left in the apex and hope that it will stay there. And later on, towards the end of the 60s decade, they developed something resembling the fixation mechanism, which was a finned or flange like a projection, that is at the distal tip. Even that was not sufficient enough. But in the mid 1960s, what was developed was a stylet driven leads. So a stylet with a central lumen, stylus could be inserted inside the lead. So it was controllable for a comfortable implantation. And you can see the proximal end of the lead tip, which is 6 mm in diameter, which can be connected to the pacemaker port. And these were all large because the single thick wire along with a usually silicone insulation, and the bipolar leads had a parallel conductor. Both were thick electrodes, and because it's parallel electrode, then the entire wire was thick and the insulation itself was silicone. So that's why it was larger. And while this was going on, the observation obviously was significant amount of dislodgements ranging between 10 to 40%. So the desire and the need for development of reasonably fixable leads was attempted, and the result was the tined leads as we use today. Initially, what was developed was a significantly larger tines, but that was difficult for implantation. So implanting surgeons at the time and also the engineers came up with a extra small tines, but that was dislodging again. So they went with a medium type of tines. And another interesting development that happened in the 70s decade was the atrial J lead. As you can see here, there are multiple tines, and if you closely observe, there is here the tip electrode, which is not right at the tip, it is slightly angulated, which was supposed to be getting a good contact with the atrial myocardium. So that was tined lead. And then the desire was even better fixation was looked upon. So that resulted in the development of the screw-in leads in 1976. There were two types of screw-in leads that were possible. One is the fixed helix. You take the fixed helix lead into the ventricle and rotate the lead itself to drive the helix into the myocardium. That is likely to entangle with the cardiac structures. Sometimes it can damage the helix itself. Then came the development of the extendable retractable screw-in leads, which are popularly used today. This was developed by a German physician, Bisping, along with Medtronic, and this is still called as the Bisping mechanism. The mechanism that are actually used today by the Medtronic leads are a variation of the same thing. So that's called as the Bisping mechanism. This came in 1976. The lead itself was a little larger, and then later on came the 5076 lead and 4076 leads and various other companies screw-in leads that you're using today. And while this was going on, another need was coming up. And what was that? Immediately after implantation, few weeks later, the threshold significantly rises and remained up for the entire lifetime of the pacemaker. And at that time, the tip electrode was actually stainless steel or platinum, smooth electrodes. So that caused a lot of polarization, and that was not an efficient charge transfer. So later on, by research, scientists found out that this can be overcome by providing a porous electrode. So they actually designed porous electrodes, smaller electrodes in geometry, or coating like platinum black or fractal coatings with titanium nitride or iridium oxide were developed. So that provided for increasing efficiency. And in the mid 1980s, in 1983, Medtronic came up with the steroid eluting lead, the steroid plug. So the lead geometric size came down, ultimately with a steroid plug inside this, the threshold started to behave nicely for right from the time of implant for the entire lifetime of the pacemaker. So the other development is reducing the size of the diameter of the lead. That was another development that came in. So while large diameter leads with the parallel electrodes, in order to reduce the size, the coaxial lead were getting developed. And initially it was a single wire coaxial lead, thick wires with silicone insulation. Later on, multi-stranded wires came in with different kinds of insulation material that significantly reduced the diameter of the lead. All that happened in the 70s and 80s. And while these insulations were experimented upon, at that time, the predominant insulation was silicone. And then they wanted a much more smoother insulation, so they moved on to the polyurethane insulation. So this polyurethane was behaving nicely in the initial stages, but later on it started developing some problem. It was getting degraded from inside the lead because of the reaction between the metal electrode, conductor electrode, and the polyurethane itself. This will be my last slide. I'll conclude after this. So this will actually this was eroding the the insulation itself. So they came. Also, the polyurethane was not being processed very well as it is today in those days, and there are different coatings that are being given in the polyurethane itself today, and then that is significantly changed. So we have better leads available today. And in that's about silicone. And polyurethane initially, what was degrading was what is designated as 18A. Now we have changed it to 55D. And later on, co-radial leads were developed, and particularly for the LV leads that are very useful. As you can see here, there are 4 electrodes, but these are single electrodes. The insulation is something called as polyimide, originally developed by NASA. So that is being adapted. Because I have run out of time, so let me conclude here. I'll straight run to the conclusion here. So evolution of pacing leads has been driven by evolving unmet clinical needs that were seen by the physicians as the implantation was going on. And the evolution accelerated in collaboration with the R&D engineers and the implanting surgeons and cardiologists in those time. And today, the leads are tested more rigorously. In the 60s and 70s, testing mechanism was not available. Today, the leads undergo significant testing mechanism. And today, you also have a lumenless lead available, which are significantly being used in the conduction system pacing. And I would like to conclude by stating that actually, the unsung hero of the successful pacemaker system is the lead, not necessarily the pulse generator. Because everyone takes it for granted, so much of engineering goes on behind that, nobody knows about it. So with all that development having gone on behind this, so with the new leadless pacemakers, I will leave with a question: are we looking at the future decades of redundancy of the leads that we know today? Thank you very much for your attention. I stop here.
Mr. Govind, we would like to have your opinion on the pros and cons of lumenless lead and lead with lumen in this era of conduction system pacing.
Okay, so as you all know that, the initial conduction system pacing became popular with the use of the lumenless lead. And then it is still being popularly used, still the major implantation. So there are significant evidence that is available. You can do conduction system pacing with the stylet-driven leads also. So there is opinion that particularly for left bundle lead placement, if you have a stylet-driven lead, that gives you a little more support for driving the lead inside. Not so much with this, but then it varies by the operators. Those who are comfortable with the lumenless leads for the LBBB pacing, they continue to do that, although they continue to experiment with this a little bit. But then stylet-driven leads are also becoming popular. I think as the lead technology develops, with additional stability of the stylet-driven leads, both will continue to have a place. And I feel ultimately, it's my opinion, but I don't think how it will pan out. So what would happen is both will coexist with a little bit of development of a stylet-driven lead. So both will have its own place in the future. You can't say this one is definitely 100% better, the other one is not so much.
Incidence of lead break, any difference in between these two kind of leads?
I do not actually, in term for the conduction system pacing, I'm not aware of the literature evidence that is available today, but then as it exists today, um, the conduction system pacing all started from the 15 and left bundle pacing from 17, 18 onwards. The amount of data that is available pretty small. I believe it's not very significantly different. I don't have evidence to clearly tell you what's the percentage.
I don't really think there is a difference with respect to any kind of breakage, because the breakage is at the fulcrum point. So once you've removed the stellate, the fulcrum point becomes same for both of them, because now they are without the stellate. Only difference is that the stellate driven lead has a much more force to go in. It goes faster, but the much more chance of perforation.
Yeah.
Because you have a lead which is being stabilized like a wire which is hitting a balloon to penetrate. So you have a much more chance to penetrate. Otherwise, as far as the breakage is concerned, since its implantation requires the stellate, once you've implanted, the stellate is out. So the fulcrum point breakage where it takes the turn is going to be probably same in both. That's what I feel.
Thank you very much for that note, sir. Yeah, so thanks for that insight. Okay, thank you.
Thank you, Mr. Govind, for your nice deliberation. So our next speaker is Mr. Savari Vasan from Abbott. He will be talking on the understanding of the timing cycle and some troubleshoot case based.
Yeah, requesting
I
Dr.
welcome
Savari
Savari.
Vasan
Stage is all yours.
to get in the dais. Thank you, sir.
Thank you very much, sir, for giving the introduction. And as you see, this is a small topic which I am going to be doing it in just 10 minutes. So let me start straight away with this. So Govind already talked about a generator which was made out of a kiwi boot polish. And this was the one which was made in 1958. And this one interesting thing about is this company which made was called Eleanor. And this company was later purchased by Pacesetter, and Pacesetter was later purchased by St. Jude, and St. Jude was later purchased and now with Abbott. So if you see, the pioneers of pacing has been with Abbott, we started off. But let us understand what was happening at that time. If you can see in this ECG, you can see it's just pacing without sensing. And this was in the VO mode, and this was the James Bond mode which was available in 1958. So James Bond means you can have the license to kill, because this can start a tachycardia, patient may die because of this. So this was a problem because there was a base rate interval without any sensing. It was in asynchronous mode or VOO mode. So now the problem starts. Now we have to find a solution. So this is how the solution and timing cycles came into being. So first thing they brought in was to see a need, which was to see what is happening in the heart, to see the P waves and the R waves. And when you see the P waves and R waves, you get to inhibit it. So that came with the VVI mode. So the timing cycle started with a base rate interval, and they added one period called alert period. And in this alert period, whatever was seen, immediately it got inhibited because of this. So this was the various other periods. I will come back to that. So we start with the alert period, which actually gave the eyes to the pacemaker. So now the pacemaker can see. So when there is an R wave or a P wave, it gets inhibited. So this is the alert period which gives the eyes. Here, the pacemaker can see and also respond. So we decided that sensing is very good. Yes, excellent. And do you see anything more in this good? If you go look deeply into this good, there is evil. So this sensing was good, yes, but it has to be appropriate. And that was the reason why it started coming with issues. And now when you have issue, you should think about some solutions. And the solutions is nothing but timing cycles and the various periods it came up with. And basically timing cycles are a flow chart by which we understand if there is a problem in the sensing, how to troubleshoot with them. And if in this ECG you can see there is more than one R wave for each beat, and that is a T wave being oversensed. So now we saw sensing is good, now we started seeing more. And if you want to see less or correct, appropriate, then we need something called as a refractive period. So refractive period is something which looks at the heart And if it is supposed to have a T wave which is always going to be followed by a R wave, so it gives you a period which is called as the refractive period over a period like 275, 300 milliseconds. So it submerges the T wave inside the refractive period. So now this is going to be a refractory sense, and it is not going to affect your timing cycles, or the new base rate interval is not going to be created here. So now this also has a problem. Now we had VBI, now we had pacemaker syndrome, and we needed a better upgraded one. So we went to the next generation of pacemakers, which are the dual chamber pacemakers, because a single lead pacemaker, nowadays many studies have come with pacing induced cardiomyopathy and other issues. So dual chamber pacemakers came in, and this is going to be an advancement. Yes, it is an advancement. In the timing cycles also it needed an advancement because it brought in different challenges when you have a dual chamber pacemaker. And this was one of the commonest things which you would have seen in many of your patients, because there is a retrograde conduction and there is a possibility of a PMT which is happening with this. Again, now we go for one period which has to help it, because this retrograde conduction happens because of a PVC, and it goes back, gets the atrial lead to sense it, and the atrial lead sequentially paces the ventricle. So this is going to be a problem, and how to take care of it. So they brought in refractive period in the atria, that is post-ventricular atrial refractive period, which was submerging this intrinsic, which is, or the retrograde conduction which is coming through. So this was the one simple way you could stop the PMT before it occurs. So this is exactly, you can see here. I'll just get the pointer here. So here you can see there is a prolonged refractive period which submerges the atrial sense, which is a retrograde sense, and calls it as AR, and this is not going to be tracked and paced. And it starts a new interval with us AP, and now this actually terminates the PMT. So one by one we are seeing. We are seeing with alert period, but now we get into problems like PMT, we have a refractive period or a post-ventricular atrial refractive period. And now there is one more period which is also pending, which we saw in the first thing. So let us look at this. So immediately after you send in electrons, there is always a polarization. It is seen only by the lead, and this amplitude sometimes is high, and it could be sensed by the device, and it can restart a base rate interval. So we needed a different period. And you can see from this picture itself, now you are going to make the pacemaker blind. And when it is blind, it is not going to do anything, because it doesn't see anything, it doesn't get inhibited, it doesn't do anything, just it keeps itself from doing anything else. So this is a period, this is what is called as a blanking period, which basically makes sure the pacemaker, even though it may sense something, doesn't do anything. So blanking period immediately follows atrial pace, atrial sense, ventricle sense, ventricle pace, and this makes sure that you don't sense your own potential again in case if you're pacing, or an after potential, both are taken care of. So that came with the objective that makes sure that you should not be having. So one of the important things what dual chamber brings in is a perfect timing. That is, you're going to have a AV interval. And this AV interval also throws up a lot of problems, because you start seeing something what happens in atria in the ventricle, or in the ventricle in the atria. And if you can see in this particular ECG, you are having a far field R wave sensing. That is, when you are pacing the ventricle, you are seeing a wave which is not a true atrial P wave, not like a retrograde, it's just a oversensing, which is because of the ventricle pace. And because of this, it starts double counting the atria, and the atria goes into AMS. So sometimes we see patients who will have 10,000, 20,000 episodes of AMS, and this is basically because of this. So the atria is seeing something happening in the ventricle, because the ventricle is getting paced at 2,500 millivolts, and this definitely going to be seen. So here you measure the time it takes, and you put a blanking period. And this is where the blanking period comes to play when it is in a dual chamber. So you have a post-ventricle atrial blanking, which takes care of this far field R wave oversensing, because it doesn't need to be seen. It's not a true sense. It has to be blanked out. So we have a blanking period. And this clearly, when you program it, that just stops the AMS in the previous episode which we saw, just comes out. And if you look at this, there is a small blanking period. And if you look at it, there is a large blanking period. There is an extended blanking period, which clearly takes care of this atrial oversensing. So far field oversensing taken care by blanking period. But when we overcome something, we always have a challenge. This pacemaker always puts a lot of challenges to us. And we have to look at various ways to take care of these challenges. And again, now if you see, there is a long gap between this. And if you closely look at it, after atrial pace, there is something being seen in the ventricle. But if you look at the ECG, there is really no event. So again, there is a over-sensing. So sensing is good, but here we are over-sensing the atrial pulse. So here we need something else, because we are pacing the atria at 3 volts, like 300 millivolts, and definitely it is going to be seen in the ventricle, because ventricle has a sensitivity setting of maximum of 2 millivolts. So this leads to the problem of crosstalk. So there is two problems of cross-channel sensing. One is the one which we already saw, but we'll come to the later. Crosstalk is something where atrial pace is seen in the ventricle. The same way, you can also have the ventricle even being sensed in the atria. Both cross channels, we will be requiring blanking periods. So blanking periods, here we have a blanking period which is programmable, which was 36, whereas it was happening at 47 and 51. So we increase it so that we will be able to take care of this patient. So you can see it was having a problem here. They increased the blanking period, it became a proper APVP. So the problem of crosstalk is taken care with this blanking period. And now there's also a lot of advancement that you need not even program everything as per the requirements, because even if the oversensing happens a little later, you can immediately, automatically the blanking period increases, and this is called as auto blanking. Also, there is another algorithm which is ventricle safety standby, which can also help you in the same thing. So in summary, the timing cycles carry a lot of burden. I think Govind said it right, because leads are the problem. And internally, if you look at the device, the timing cycles are the one which troubleshoots the end for the better pacemaker functioning. So every problem, yes, it is solvable with timing cycles. So there is no age restriction for a dual chamber pacemaker rate responsive patient. He can enjoy life and he can have a wonderful life with pacemaker, because we are taking care of all these problems with timing cycles. So with this, I conclude. Thank you very much, sir.
Thank you, Savary. With your each presentation, we always feel enriched. The thing is that, can you just tell me one thing, that in a young patient who has been implanted with a double chamber pacemaker, what is the importance of this maximum sensor driven rate in DDDR pacemaker?
So maximum sensor driven rate, as you know, patient probably was a 6 sinus patient, or probably was a chronotropic incompetent patients. So in those patients, definitely you need not worry about it, you just put on this. Some patients, as you rightly said, a young patient who has his own rate, at the same time you want to program the sensor rate, you have to make sure that whether the sensor is not very aggressive, it is very less. So only when there is a requirement, it comes in. Until then, it will be on its own. But if you put an aggressive sensor, then it will start competing with the atrial intrinsic rate as well. So
thank you.
We have separate programmabilities for sensors so that you can do it.
Thank you. Is there any question from the dais, from the audience?
Only one important thing is about the crosstalk. If you have an atrial event sensed in the ventricle leading condition, I think this crosstalk is almost gone, because now there is ventricular safety pacing. So in an interval which is less than the AV, you will have a ventricular pacing. So the crosstalk is now almost gone with the new pacemakers.
Very correct, sir, because these are things only we can present. Practically, these are all taken care of. Yes. So that's the beauty of the timing cycles, they are taken care of it. Thank you very much, sir.
We conclude the session here.
Okay, such a beautiful session. We're moving to the next session directly, the medicine and EP. For this session, I request Dr. Shubhra Banerjee and Dr. Rakesh Charka for chair the session. And So, so our first speaker, Dr. Jayasankaran Gujral, I request sir, please be in the dais and present your presentation. Thank you.
So Dr. Gujral is going to talk on considering anticoagulation therapy beyond conventional risk scoring. Over to you, Dr. Gujral.
Afternoon, everyone. So at the outset, I would like to thank the IHRS organizers for giving me this opportunity. And my topic is considering anticoagulation therapy beyond the conventional risk scoring. And I'm assuming we will be discussing about non-valvular atrial fibrillation and about how the past has been regarding risk stratification in terms of stroke and how the future will be. So we all understand that AF is associated with a 5-fold increase in the risk of stroke, and up to 1/4 of the strokes actually they can be attributed to atrial fibrillation. In general, strokes resulting from AF tend to have higher severity, higher disability and higher mortality. So it is understandable that we need to prevent these strokes, and for that we have risk stratification source. With the advent of novel oral anticoagulant agents, now the risk of bleeding has less than 0.5%, which means that even low risk patients who have any risk of stroke should be given anticoagulation, which means we need more and better risk stratification scores for the same. So as the time evolved over the last 3 decades, initially we had risk categories like the AF investigators risk category, like the ACC AHA scores, and subsequently in the late 90s we had the CHATS-2 score, and then in 2010 came the CHATS-2-VAS score. And we have been sticking on to CHATS-2-VAS score till times immemorial, I believe. And even the current ACC and the ESC recommendations, they also recommend use of CHATS-2-VAS score for risk stratification. However, we need to know whether these are ideal or not. So this is the ROC curve of all the scores that came before the CHATS-2-VAS score, and we can see the ROC curve indirectly represents the accuracy of the test. The dotted line shows us that the test is the ROC of the curve is C statistic is around 0.5, which basically means the test is equivalent to tossing a coin. So more is the area under the curve, better is the test. So we believe all the tests here had a C statistic of close to 0.5. It was around 0.5 to 0.6. So the predictivity of all these tests were modest. With the CHATS-2-VAS score, we became slightly better off. Now, in patients who did not have AF and we wanted to predict stroke, the statistic was around 0.71. But in patients with AF, again, it was 0.58, which was not greatly better. So why I've been sticking on to this score? Because it is easy to use. You can use it on the go, and it has all the clinical risk factors. But there is a lot more to be done in this scenario. So we all know about the CHATS-2-VAS score. One update, the current ESC recommendations, they recommend not using female gender as a risk modifier. It was never a risk factor, it was a risk modifier. So the current recommendations, they have excluded female gender from the CHATS-2-VAS score. So there are certain weaknesses associated with the CHATS-2-VAS score. First is that this score, when it came, it was validated in the Hispanic population. It was also subsequently validated in the Europeans, but the score never got any validation among the Asians. The other problem is a patient who has been just diagnosed as hypertension and is now well controlled has the same risk as a patient who has been having hypertension for 10 years and is uncontrolled as per the CHATS-2-VAS score, which is again a problem. It does not give any acknowledgement to physiological contributors to stroke risk like LA function, LA size, LA shape, and then it does not differentiate between different types of AF, because whatever data has come in the last decade regarding the risk of paroxysmal AF versus persistent or permanent AF has not been incorporated in this score. So we have had 2 more clinical risk scores after the CHATS-2-VAS score, which have added some more clinical risk factors into it, like the ATRIA score. It added proteinuria as well as EGFR, low EGFR into the picture. The test performed modestly better than the CHATS-2-VAS score. However, again, the C statistic was the same, around 0.66. Then we have had the Garfield AF score. It added some more clinical variables like diastolic BP, ethnicity, smoking risk, dementia. But the C statistic again did not improve beyond 0.7, which meant there was more to be done. So the question is there a world beyond the clinical risk factors which can help us determine the risk of stroke in these patients with AF? Answer is yes. So more recently in 2014, it has been hypothesized that similar to the risk of thrombosis as is predicted by the virtuous triad, we can also have the similar triad which is predicting the risk of stroke in patients with AF. So we can have endothelial injury, stasis and hypercoagulability which predispose to stroke. So endothelial injury is something which can be predicted by cardiac troponins. Stasis, as in because of a cardiomyopathy, can be predicted by the anti-proBNP. And hypercoagulability obviously can be predicted by D-dimer and fibrinogen levels. Now, two of these variables have been extensively validated in multiple sub-studies, that is TROP and anti-proBNP. We had the RELY sub-study which showed that TROP and anti-proBNP had independent and strong association with stroke and mortality. And this was independent of the confounding variables which are present in the CHATS-2-VAS score. Subsequently, we had the ABC-AF score, which in addition to age and clinical risk factors also has biomarkers, that is anti-proBNP and cardiac troponins. So this score has been again extensively validated now in patients who have AF, in patients who are receiving anticoagulation, who are not receiving anticoagulation, and also in patients, elderly patients who still do not have AF and anticoagulation. So it has been validated in all the three groups. And the only key thing remains is that this trial, this score has not been compared with CHATS-2-VAS score in a randomized fashion. And this study is actually ongoing under the NIH sub-study. So once the result of this study comes, I think this study will make into the guidelines, and we'll be probably using this along with the ABC-AF score to risk stratify patients. There are many other biomarkers, the study on which is ongoing, but there is no conclusive evidence as to if these biomarkers can predict stroke in low-risk patients. The other question that we need to answer is whether what is causing stroke in patients with AF? Is it actually AF, or is it the substrate which is leading to stroke as well as AF? Time and again there have been studies which have indicated that there is no temporal correlation between occurrence of AF and occurrence of stroke. So it is now felt that it is actually the atrial substrate which is diseased, which is leading to both AF and stroke, and we need to predict this substrate instead of maybe calculating the AF burden. So again, same picture, we have to predict atrial fibrosis or atrial cardiomyopathy through various risk factors as we discussed, and of course there can be triggers which again are not defined as of now. Once a disease substrate, once a trigger happens in a disease substrate, that is when AF happens and that is when thromboembolism happens. So probably we need to focus more on the atrial substrate. On the same pretense, atrial cardiomyopathy has been discussed and defined by the 2016 consensus, and they believed, based on the pathological findings in patients with AF, that you can have 4 different classes of atrial cardiomyopathy, which is classified based on the pathological studies. We cannot do pathology, we cannot do biopsies in these patients, so we need non-invasive markers which can predict atrial fibrosis using echo, cardiac MRI and MR-angio. So now all the future of stroke assessment in patients with AF is resting on guiding the atrial substrate. So this is one interesting study which was published back in 2013. So what they did was they did MR-angio of patients who have had stroke and who have had different types of atrial fibrillation. So what they found was the usual shape of the left atrium was discoid as seen in panel A. And this shape was progressively becoming spheroidal in patients who have had longer durations of AF. And it was found that this LA sphericity had a direct independent association with stroke and mortality. And even in these patients, AF ablation was not durable. So now we have had LA fibrosis scores which can be predicted by delayed enhanced MRI, and we can actually categorize fibrosis based on the degree of enhancement. With the increasing enhancement as seen in these images, the stroke risk increases. The line in red that represents the fourth stage, that when your fibrosis is beyond 50%, and the stroke risk is maximum in this group. Again, this is an independent association excluding all the confounding variables. So basically it means that we need to focus now on the atrial substrate rather than focusing our attention on only clinical risk factors. And this needs to come into the clinical risk score. Something simpler that we do day in, day out, we can do strain imaging. Now there are dedicated softwares available in India. And now there have been studies both in healthy individuals as well as in individuals with AF. And it has been shown that LA strain, again, reduction in LA strain would mean increase in stroke. Increase in LA strain means reduction in stroke. So to summarize my talk, we currently are sitting basically at the same level where we were sitting in 2010. We are still using clinical risk factors to guide our stroke risk assessment. However, this is easy to use, but they have very poor predictive value. It ranges around 0.6 to 0.7 in terms of the C statistic. We need a risk stratification score which truly identifies low risk patients who will benefit from novel oral anticoagulating agents because of the low risk of bleed. And for that, we need to add more things. We need to add biomarkers into it. And so the future of stroke risk assessment will depend on 4 pillars. In addition to clinical factors, I believe imaging, biomarkers and AF type will make the cut in this. In biomarkers, as of today, anti-BNP and high sensitivity troponins have been extensively validated. And imaging is still probably a talk of the future because, again, imaging to guide fibrosis has not been validated in any large scale studies. And LA strain, again, it has not been standardized like the LV strain. Thank you.
That was an excellent talk, Dr. Gujral. Thank you very much. As you have shown, actually, that the SHADS-VAS score is the most popular and widely used, but I think it's far from ideal. And there's several other factors which we need to take into account. And the difficulty is also to put individual weightage to each of the factors. So in such a circumstances, do you think in near future, AI may be of much help, where they can put in a weightage and also come out with a score which would have the weightage of the individual factors put in?
Yes, I believe so. There have been trials focused on AI and using the SHADS-VAS score. They have not yet yielded the desired result. But I believe when fibrosis and atrial imaging comes into the picture, I think AI will hold the key.
Yeah, agreed. So, any other?
Yeah, any more questions from the floor? So, along with the biomarkers and the imaging, what I personally feel, it's not a prejudice, but I feel the baseline ECG POFs might be considered at some point to consider for some of the risk factors which might throw some light, like your P wave width or kind of your morphology sometimes might be helpful to understand whether we are dealing with a diseased atrium or not. I'm not sure whether it will be validated or is there any literature like that?
Yes. So again, blocks like interatrial block, Bayes syndrome, and you have low voltage P waves, wide P waves, terminal negativity in V1, all these things they are indirectly indicating our substrate. So they by themselves have not been validated in huge studies, but
Yeah.
they will again indicate the same thing that
Right.
we have been trying.
So if we just go for initiating the anticoagulation, I mean, go for all the time like imaging, which are actually costly and you know, in our resource poor setting, we can't go ahead all the time with the imaging like MRI or all other things. So in that case, if there is any validation from the ECG, looking at the baseline POF, so I think that will be a great thing to
Yes,
consider.
I truly believe so.
If there is no other question, thank you, Dr. Gujral, once again. And I think we have to move on to the next talk. I think Dr. Javed Parviz is with us here, and he's online. Could we connect to him? And he's going to talk on approach to anticoagulation therapy in device detected AHRA. Welcome, Dr. Parviz. So, yeah, you can start.
I'm just waiting for them to load the recording. I begin, I must thank the organizing committee IHRS for giving me this opportunity to deliver this talk in front of this August gathering. And again, because of some pressing issue, I could not attend the IHRS, personally. So again, thanks to the organizing committee for allowing me to do this in virtual. So the topic given to me is approach to anticoagulation therapy in device-detected atrial high rate episodes. So this will be content of my presentation, and we'll start with the definition of AHRE episodes or subclinical atrial fibrillation. The atrial high rate episodes have been defined variably by different investigators over the past decade. In the European Society of Cardiology guidelines in 2020 defined the atrial high rate episodes as cardiac implantable device detected atrial tachyarrhythmias with rates of 170 to 220 beats per minute. There should be around 20, more than 20 beats, and the duration could be from more than 6 minutes to less than 24 hours. And the atrial arrhythmia should be documented on the EGM available from the devices, and the EGM should be available for analysis and exclusion of any of the noise artifacts or double counting. There should be an absence of documented atrial fibrillation and absence of typical symptoms of atrial fibrillation, and there should not be any history of atrial fibrillation. And there are other terms such as subclinical atrial fibrillation and device-detected atrial fibrillation, which are more or less synonymous, and they differ very minutely between individual trials. And more or less, this is the consensus with regards to definition of atrial high rate episodes. So this is from ACC 2023 HRS atrial fibrillation guidelines, and you can see here this is the guidance regarding AHRE management, and then you can see here there are 3 zones: the green zone in A, and the orange zone in B, and the red zone in C. So you have atrial high rate episodes of different spectrums, that is from 6 minutes to 5.5 hours, more than 5.5 hours, and 24 hours. So in all these patients with very low risk or low risk of CHADVASC, these patients are considered at low risk of stroke and thromboembolism, while at the other end of extreme are patients with high CHADVASC risk and AHRE episodes more than 24. These patients are almost equivalent to clinical atrial fibrillation, and they should be treated if the stroke risk is high with oral anticoagulation. In between is the area of knowledge gap, where the patient has in between intermediate or high risk of CHADVASC, while the AHRE duration is either from 6 minutes to less than 24 hours. So the Artesia and NOAA trials were initiated to provide some evidence in this knowledge gap. And what is already known regarding atrial high rate episodes from different observational analysis and studies is that almost 1 in 3 patients who's implanted a device which is capable of documenting atrial high rate episodes, almost 1 in 3 patients of elderly patients with such device do document AHRE episodes. And the AHRE episodes do not increase the stroke risk same as clinical atrial fibrillation. The atrial fibrillation increases the stroke risk in elderly population almost by 4 to 5 folds as per the Framingham study, while the AHRE episodes increase the risk of stroke by 2 folds. And almost 30% of the patients who have these AHRE episodes develop clinical atrial fibrillation by the end of 2 years. And patients with AHRE more than 24 hours from the ASSERT trial, they should you receive anticoagulation if they have high risk of stroke or thromboembolism. Uncertainty exists regarding AHRE episodes if they are less than 24 hours, whether more than 6 minutes and less than 24 hours, whether these patients should be anticoagulated or not. To answer this question, we looked into the data provided by these trials such as ASSERT, LOOP, NOAA, AFNet, and Artesia. Predominantly, NOAA and Artesia trials we look into much more detail. So this is the NOAA AFNet trial. Uh, this came almost in the last year, and this was the first trial to investigate safety and efficacy of anticoagulation in atrial high rate episodes but without documented clinical atrial fibrillation. A moderate sized trial, almost 2,500 patients, were randomized to two arms, that is to receive edoxaban versus placebo or aspirin, and the entry criteria included patients with more than 65 years of age, AHRE more than 6 minutes, or with more than one additional risk factor of stroke, such as diabetes, hypertension, and diabetes, hypertension, heart failure, vascular diseases, prior stroke. Patients with documented atrial fibrillation, DAPT, or recent ACS PCI were excluded from the trial. The trial was basically terminated prematurely at the end of 12 to 14 months because there were safety signals and there were concerns regards futility for the efficacy of all after all enrollment of the all planned patients. So this trial, the primary composite efficacy outcome included stroke, a systemic embolism, and CV death. And you can see that efficacy outcome was not clinically significantly different between the two groups, that is edoxaban versus placebo. While the safety outcome, which was a composite of death from any cause, CV death or major bleeding, was seen much more in the edoxaban arm, and that was primarily because of major bleeding. While looking into the Artesia trial, which is apixaban for stroke prevention in subclinical atrial fibrillation, this trial was published in again NEJM, and it came almost 75 days after the NOAA AFNet trial, and it had almost 4,012 patients who were randomized to apixaban 5 mg or 2.5 mg BD versus aspirin 81 milligrams OD. And the inclusion criteria included patients with AHRE episodes more than 175 beats per minute, and the duration was between more than 6 minutes to less than 24 hours. Also, these patients had another high risk factors for stroke, and the CHADVASC was more than equal to 3. And the patients with clinical atrial fibrillation, major bleeding events, and CKD with creatinine clearance less than 25 were excluded from this trial. And looking at the results at the end of 6 years, the primary efficacy outcome was stroke or systemic embolism, and almost 86 patients had a stroke or systemic embolism in the aspirin arm versus only 55 patients in the apixaban arm. And as per the statistical analysis, the hazard ratio was 0.63, and with a 95% confidence interval, the p-value found came to be highly significant. So that apixaban definitely reduced stroke according to the Artesia trial. Looking at the major efficacy outcome, the major bleeding was seen in 86 patients in the apixaban arm versus 47 patients in aspirin arm. So definitely there was an increase in major bleeding. But only these numbers do not tell the entire picture. We need to look into little minute details of the outcome from this Artesia trial. So this is the on-treatment population outcome. So you can see that stroke or systemic embolism almost occurred in only 36 patients in apixaban arm versus 65 patients in aspirin arm. Out of that, much more important thing is if you look into the disabling stroke, which was defined by Rankin score more than 3 to 6, almost 29 patients had a disabling stroke in aspirin arm versus only 11 in the apixaban arm. So almost 1/3 reduction there. And when we look into the bleeding, definitely major bleeding was much more in the apixaban arm, 86 versus 47 in aspirin arm. But fatal bleeding was similar between these two groups, and majority of this bleeding was attributed to GI bleeding. 45 patients in apixaban arm versus 20 in aspirin arm. If you look into bleeding in much more detail, obviously the number of bleeding events were higher in the apixaban arm versus aspirin arm, but majority of these, bleeding events were manageable by using just supportive care, and the fatal bleeding events were equal between both the two arms, and the death, unavoidable death again, was in fact much more in the aspirin arm compared to the apixaban arm. So almost these two trials at the outside look at, seems to be arriving at different conclusions. So both the trial investigators came together for this meta-analysis, and the meta-analysis showed that actually NOAA, AFNet and 6 and Artesia trial results are consistent with each other, and in both these trials there was a trend towards reduction in stroke with using oral anticoagulation at the expense of bleeding, but that major bleeding was manageable by usage of simple terms such as transfusion and supportive measures. It did not result in much difference in terms of death. So the key points while coming at analysis of these different trials, that NOAA and Artesia trial are different from each other in many terms. Terms such as entry criteria, the agent primarily agent used, and the primary efficacy outcome on points. So basically in NOAA AFNet trial they have included CV death as one of the efficacy outcomes, and as you can see, many of these patients were elderly and they had multiple comorbidity risk factors for CV death. So anyways, CV death was supposed to be higher in these patients. So in the Artesia trial, they did not include CV death as a primary efficacy outcome. They included only the stroke and systemic embolism. And Artesia trial had much more, enrollment, and it was much powered to detect the difference between stroke in these two arms. And in both the trials, the stroke risk was 1 to 1.2% per year. Important thing to understand that in the Artesia trial, almost 43% of the strokes that occurred had disabling or fatal strokes. HRS 2023, ACCHA HRS 2023 guidelines have stated that if the stroke risk is 1% or above, it is a reasonable threshold to start anticoagulation. And anticoagulation definitely results in fewer strokes at the expense of bleeding, but one should understand that this bleeding is manageable conservatively in 90% of the cases in both these two trials, and there is not an increase in fatal bleeding or death. Again, there is a sub-analysis which came up from this Artesia trial, where they looked at the Chadwick score as well as the risk of bleeding in the apixaban and aspirin. And what they found out was, whenever the Chadwick score was more than 4, and these patients had high risk of stroke, and these patients, when they were put on apixaban, the stroke benefit reduction outweighed the risk, while as if the Chadwick score was less than 4, the low risk of stroke was there, and the bleeding outweighed the benefit. Similarly, another sub-analysis showed that the patients from this Artesia trial, that if the patient had vascular disease, which was defined as stroke or a coronary disease or a peripheral vascular disease, again these patients tend to benefit higher with higher stroke reduction and compared to the risk of bleeding. So coming to the conclusion, these are the certain factors when we decide upon oral anticoagulation in patients who have got device-detected atrial fibrillation. We must understand that we have to estimate the stroke risk in this population. If the stroke risk is 1% or above, then it is individualistic decision model, and these patients may benefit by using anticoagulation. And the stroke risk can be modified by the Chadwick score. If the Chadwick score is 4 or more, then these patients are likely to benefit with the anticoagulation versus risk of bleeding. The longer the episodes or more frequent the episodes, again there is a higher chance of reduction with this oral anticoagulation. We must understand that the DOAC reduces stroke by 32% in this population. It does increase bleeding by 62%, but it does not have mortality. We must also involve patient into the discussion. Some patients may place high emphasis on avoiding stroke because many of these strokes can be fatal or disabling, and the risk or the anxiety or the apprehension regarding the bleeding can be discussed, that majority of the bleeding is manageable conservatively. And we must understand that although we are the strokes which we are avoiding are very few in this population, because the stroke itself is 1.2 to 2%, less than 2% in these trials, but majority of the strokes that we are preventing are fatal or disabling strokes. And at what expense? At the expense of bleeding, which is 15% around, and which is rarely fatal or life threatening. So again, there are certain future directions for this. That is, we are awaiting sub-analysis of the Artesia trial, where the investigators are looking at certain echo-based criteria such as the atrial size, the atrial cardiomyopathy, or looking at certain biomarkers, blood biomarkers, to find out whether what subset of patients in the AHRE episodes, patients with AHRE episodes may derive the maximum benefit with the usage of oral anticoagulation. So with that, I conclude. If there are any questions, I will be happy to take them. And thanks once again to the organizers, and congratulate them for a wonderful conference. Thank you.
Thank you, Dr. Pervez, for the very informative and talk that you gave. You did mention like the post-hoc analysis of the study, which you mentioned of the your Artesia study. They did find out, as you have mentioned, like those with history of stroke, history of vascular disease, and those are high Schatz-VAS score more than 4. They are at a higher risk of stroke than the rest. And I think also another interesting finding was those who had an episode of AF, which was within the AF means HRE, which was in the last 6 months, they had a higher risk than those without that.
Healthcare system about 30 years ago, Medicare decided that they're going to come up with a Medicare physician fee service.
Sorry, there was some interruption somewhere. Okay, yeah. So that's a comment, and could we just, Dr. Majumdar would like to ask a question. Over to you.
Hello, Javed, Dr. Suchit.
Yes, sir.
So,
Yes, sir.
this AHR is a very heterogeneous group, what sir was telling. So, there should be some way to characterize them regarding their irregularity, maybe some EGM related. So, that is, I think, this device company should look at, not club them all under AHRE and this thing. Number 2, one of these reason of AHRE is a sleep apnea, which is quite common. I have found patients who have AHRE, and if you treat the sleep apnea, this reduces. Now, there are some devices which has come for algorithm on sleep apnea management, and maybe the correlation between sleep apnea and AHRE. What is your idea on this?
Definitely, sir. I think this is something which must be looked upon, and we have now a lot of population of these patients who have these CIEDs, and definitely, to my knowledge, I don't know of a trial or a study where somebody has systematically looked at the usage of the BiPAP or CPAP therapy with reducing AHRE, but definitely something that should be looked upon, but because that will be one of the treatable causes of atrial fibrillation or AHRE.
To answer your question, Shuchit, I think if we, by definition, if you are saying AHRE, then we are excluding those patients where we have looked at it's assumed that we have looked at the EMG and excluded those patients who would have, where we think it could be an artifact. So these are the ones which is excluded, isn't it?
Artifact I'm not telling. For example, the AHR is defined on the rate. That is based on rate and then the time. These two things come while assessing AHRE. It doesn't look at irregularity and the EGM variation. So beat to beat EGM variation is something which can be easily put into an algorithm of a device company. And they should classify AHRE as likely AF or unlikely AF, something like that. And also there are algorithms, some companies have come with algorithm of sleep apnea into their device. I don't know about pacemaker they have put or not, but some other devices they have put. So they can correlate.
So this way you can exclude the atrial tachycardia as well.
Yeah, means
with the irregularity thing, because that's often difficult.
Correct. So I am not telling that those needs a different treatment or what is, that is a debatable thing, because a patient having an AF and an atrial tachycardia together has a significance of AF only. So the company it keeps is important, but at least we should this thing.
Yeah, yes, so a couple of things on top of what Dr. Banerjee and Dr. Majumdar added. So whenever we are trying to look at the AHRE, we need to understand the indication of the pacemaker as well. Like if we are dealing with a 6 sinus patient predominantly, and we are dealing with some kind of SA nodal pathology, so it is not very unusual to get atrial fibrillation even in a very short spell or kind of paroxysmal fashion. Whereas if we are actually dealing with something like a very young patient or cardiomyopathy patient where we can expect some amount of atrial tachycardia as a part of the disease process, or as a as part of heart failure when heart rate actually is going high, and sometimes it is not unusual to coin it as AHRE. So in those cases we need to understand the indication of the device, and as you mentioned, Dr. Majumdar, that that some of the devices like Boston has come up with his device like Accolade. So they use some algorithm to identify the substrate of OSA. So in that case, the same patient who has been qualified for pacemaker, as well as if he is diagnosed subsequently as OSA, So there might be some reversible component of this atrial tachycardia component, or I mean, if it is not a short run of atrial fibrillation.
So if there is no other question, so we would end the session. So thank you once again, Dr. Parvez, for being with us.
Thank you, sir.
Thank you.
So yeah, so we are actually completing our whole scientific session for the day here, and would be requesting all of the faculties and delegates to just attend Mohonar Hall for the valedictory session. Thank you. Yeah, so there will be prize session followed by the valedictory. Yeah, kindly join in Mohonar Hall.
Well, thanks to all once again. So we are concluding today's sessions right here. So we'll meet. So we'll meet Dr. Nayar's hall, first floor.